може бути впевненим у випадкових партнерах. Тому Макс обирає доконтактну профілактику PrEP. PrEP – це таблетки, які не дають вірусу інфікувати організм. Їх приймають щоденно або ситуаційно до та після статевого контакту. Всесвітня організація охорони здоров'я рекомендує PrEP людям, які практикують незахищений секс, мають кілька сексуальних партнерів або партнера, який живе з ВІЛ. Завдяки PrEP Максим залишається здоровим та має свободу вибору. Він думає про себе, про нього та про неї. Подумай і ти. Обери безпечне життя зі свободою вибору. Захисти себе та інших. Зателефонуй на гарячу лінію з питань ВІЛ-СНІДу та завітай на сторінку Центру громадського здоров'я.
Шановні колеги, добрий день. Дозвольте розпочати другу національну конференцію з міжнародною участю з доконтактної профілактики ВІЛ-інфекції в Україні за межами звичайного захисту. Організатором даної конференції є Центр громадського здоров'я Міністерства охорони здоров'я України. Дана конференція організована за підтримки Глобального фонду по боротьбі з ВІЛ-СНІДом, туберкульозом та малярією та програми PrEP. Також дана конференція організована за активної участі національних стейкхолдерів та міжнародних партнерів. Метою даної конференції є посилення спроможності якісних послуг доконтактної профілактики ВІЛ-інфекції в Україні шляхом забезпечення національного діалогу усіх зацікавлених сторін. У процесі даної конференції ми зможемо обговорити ті напрацювання, той досвід, який ми маємо з доконтактної профілактики, також обговорити ті бар'єри, виклики є на шляху доконтактної профілактики та намітити плани на майбутнє. Трансляція даної конференції відбувається на сторінці Facebook, YouTube Центру громадського здоров'я та на сторінці конференції. Тож можна буде переглянути дану конференцію згодом. Модератором даної конференції першого дня є я, Лариса Гетьман, завідуюча відділом координації програм діагностики та лікування ВІЛ Центру громадського здоров'я, та Наталя Подольчак, заступник директора CDC з програмних питань. Декілька буквально організаційних питань перед тим, як ми офіційно вже відкриємо конференцію. Дана конференція забезпечена синхронним перекладом на англійсько-українську мову. Тож для того, щоб ви могли скористатися зручною для вас мовою, будь ласка, на панелі знайдіть кнопку «Переклад» та оберіть потрібну для вас мову. І для того, щоб уникнути якихось шумів або скористатися саме тим перекладом, який необхідно, вимкніть клавішу «Оригінальний звук». Перевірте, будь ласка, чи ви зареєстровані під тим іменем, яким ви бажаєте. І якщо все-таки ви зареєструвалися під юзером чи якимось іншим ім'ям, то, будь ласка, перереєструйтеся. Для цього оберіть в закладці «Учасники» детально та переіменувати. І для того, щоб ви могли скористатися перекладом, будь ласка, ви повинні зайти саме через програму Zoom, а не через браузер. Тоді переклад буде забезпечений в достатній мірі. І я передаю вітальне слово заступнику міністра охорони здоров'я, головному державному санітарному лікарю України Ігорю Кузіну. Будь ласка.
Так, шановні колеги, шановні друзі, доброго дня, і я дуже радий усіх бачити. Дуже приємна новина, що сьогодні ми маємо вже 310 учасників на нашій другій конференції, яка присвячена питанням PrEP. Дійсно, державна стратегія протидії ВІЛ-інфекції, СНІДу, туберкульозу
is fully synchronized with the global objectives. Accordingly, Ukraine has to reduce the burden of HIV and TB and virus hepatitis till 2030. And of course, achievement of such global objectives is not possible unless we can cooperate closely, unless we provide social support. And the key thing is liaison of the National Health Service, Center of Public Health as leaders of public structures in promotion of health. And this cooperation is called to achieve the objectives of the strategy of countering and prevention of HIV/AIDS. We realize that unless we involve patient organizations, non-government organizations, our partners with international experience, achievement of success is not possible. Comprehensive service of prevention for each citizen is a priority for our country. To overcome HIV, we use different methods of prevention, also antiretroviral therapy for treatment of HIV. We provide access to free of charge testing to every Ukrainian if they need that or have the willingness. The citizens can freely select preventive screening.
Наші міжнародні партнери надають нам ґрунтовну підтримку для посилення спроможності програм профілактики та досягнення сталості даних послуг. Міністерство охорони здоров'я України всебічно підтримує існуючі програми, які спрямовані зараз на профілактику ВІЛ-інфекції. Наразі Україна закупляє препарати завдяки підтримки CDC і Глобального фонду. Мається на увазі саме препарати для доконтактної профілактики. Але в недалекому майбутньому доконтактна профілактика має закуповуватися за гроші державного бюджету. Доконтактна профілактика ВІЛ – це послуга, яка є...
Contact prevention of HIV is a service that will be provided free of charge throughout the country, comprehensive with other methods of prevention. This is quite a new method of prevention of HIV, based on the evidence base, also experience of other countries that already began the programs of pre-exposure prophylaxis. We decided to actively use pre-exposure prophylaxis. It protects every client. However, by fulfilling our ambitious plan, expanding the plans, we can affect the rights of expansion of HIV on the population level and to reduce the number of new infections. And this will demonstrate the success of this program.
So in the
implementation of pre-exposure prevention is a comprehensive that which includes testing, treatment, achievement of prevention, effect.
So through testing, so if the test is negative, so the HIV is not transmitted. So the program can be provided only with the help of so this program is aimed on the health professionals, on the volunteers and all NGOs that will promote the pre-exposure prophylaxis in the present and in the near future. So I would like to invite all the colleagues to the discussion, to the open discussion, and I'm very happy for us to have this opportunity to really discuss this important issue. Thank you. Thank you very much, Igor, for this welcome speech, and it was very important for us to hear this inspiring words. And now we provide the floor to Roman Rodina. Thank you. I'm very happy to welcome you here, dear colleagues, on the second Profilec conference beyond the conventional protection. Every year, we do over 2 million of HIV testing, and over 1 million of people they get the bad news that they are infected with HIV, and but unfortunately, over half they're not aware about their status, and that's why we decided to create a PrEP or pre-exposure prophylactics. So we started to promote PrEP yet since 2019, and through this year, PrEP was used over 4,000 of people all over the country. Pre-exposure prophylactics is available for older people, as well as in big cities, in small villages, in locations. And we implemented the standard of PrEP, and it was approved by the order of Ministry of Health of Ukraine. So the pre-exposure prophylactics has already the normative base, and PrEP is free of charge, and it will stay free of charge. And this method that is combined with other methods should provide and is providing up to 99% of protection for the clients in population. I would like to say here that Ukraine is the leader among the countries of Eastern Europe in implementing PrEP. We have the ambitious goal to reach the coverage of persons up to 15,000 for the year 2023. So, and I would like to express my gratitude to our partners and donors that help us to implement the method of PrEP. And I would like to say that the collaboration will be progressing and will be maintained all together with international partners as well as the Ministry of Health of Ukraine. And we hope that through this cooperation, we will reach our goal. I would like to say that all the health professionals in Ukraine makes its own input in daily combating HIV, and we aim at providing the equal and barrier-free PrEP as the health of the population stays in focus of our efforts. So the PrEP can be delivered to any person of having a high risk of HIV infection, and those who are willing to start using PrEP. And I would like to say that the COVID-19 pandemic was a great challenge for us, but this pandemic didn't impact the pace of PrEP, and we managed to proceed with our work. And I would like to say that this program is one of the dozen steps of ours to reach our aim that we put for ourselves. This is the health of our population. Thank you. Thank you, Roman, for your welcome speech, and thank you for keeping up to your action plan, notwithstanding the COVID pandemic. And now I would like to provide the floor to the Senior Manager, Darren Dorkin.
Thank you very much. Good morning, dear colleagues. Thank you for your kind invitation. I'm very pleased to provide opening remarks to support this important second national conference on HIV pre-exposure prophylaxis. The Global Fund welcomes this conference on PrEP as part of our joint efforts to fight the HIV epidemic in Ukraine. First, on behalf of the Global Fund, I wish all people of Ukraine increased health and safety during the COVID-19 pandemic. Ukraine has advanced in its design and implementation of its PrEP program since the pilot in 2017, as we just heard. On a policy level, Ukraine has made significant progress. The country's national strategy for HIV/AIDS, tuberculosis, and viral hepatitis through 2030 includes ensuring access to PrEP for key populations. The new national guideline on HIV prevention includes PrEP and PEP standards, and amendments to MOH Order 585 include PrEP rollout from AIDS centers to all medical facilities and PrEP initiation by non-infectious disease physicians. At a programmatic level, the PrEP scale-up plan has advanced with promising results in coverage, as we've just heard, and contains ambitious targets, as also Vermont mentioned. The ongoing Global Fund grant, covering 2021 to 2023, which totals over $135 million US dollars, includes financing for a wide range of interventions to support PrEP scale-up. The interventions are differentiated by key populations for people who inject drugs, MSM, sex workers, and people in prisons. The grant will also purchase PrEP drugs and assess demand and supply factors affecting PrEP impact to help improve implementation. Although progress has been made, we need additional joint efforts to successfully scale up, to reach the targets that have been set and even beyond. For example, WHO conducted a virtual mission on PrEP implementation in late 2020. There were 12 recommendations. While we'll not list them, it is important to increase our work together to fully implement the recommendations and further support scale-up and sustainability of the PrEP program. Lastly, as also been mentioned, the COVID pandemic continues to require mitigation and adaptation measures to ensure that PrEP access is protected, continued, and expanded where possible. Among the options available, we recommend using different systems for drop-off of commodities, collection at different community distribution points, providing a longer duration of drugs to clients, and SMS or other communication tools for follow-up and adherence support, and online demand creation wherever possible. Of course, all these efforts, as has been mentioned, absolutely require the support of community-based organizations, and we appreciate that in addition to all the international partners, national stakeholders, the leadership by the Ministry of Health, and all actors involved. We look forward to continuing working together with all partners to support our concerted efforts to scale up PrEP and fight HIV in Ukraine. I wish you all great success in your work. Thank you very much.
Дякуємо, Дарин. Дякуємо за підтримку глобальному фонду.
Thank you very much, Darren. Thank you very much for the assistance to Global Fund, for technical assistance, for helping us to purchase the PrEP drugs, and also to emphasizing the role of the NGOs in this progress. And now we provide the floor of Martin Donahue from WHO in Ukraine office.
Yeah. So good morning, good afternoon, dear friends, colleagues, participants. It's so great to see some of you here on the screen. On behalf of World Health Organization, I'd like to welcome you to this conference, which provides a really excellent opportunity to share experiences regarding PrEP, international and national experience. But more importantly, it should inform our next steps in scaling up PrEP so that ideally everybody who could benefit from PrEP can receive it. This is very ambitious. This is a very ambitious undertaking. I encourage you to use these next 3 days to develop an even more ambitious plan for scaling up PrEP. You've already been congratulated on the existing ambition within the PrEP targets, but as Darren alluded to, we could certainly be even more ambitious. And I would really encourage you to use the international and some of the national experience to think about simplifying PrEP services. The reason I want to dwell on this a little about simplification and scaling up is that we only relatively recently corrected some of the mistakes of the past with regard to antiretroviral therapy for HIV populations. I say relatively recently, when you've been around doing this for as long as I have, anything less than 5 years ago is relatively recent. And I think we know what those mistakes were in the past, that antiretroviral therapy was historically overregulated, sometimes poorly implemented and limited. Let's not make the same mistakes in the same areas with PrEP. Let's not make it too overregulated. Let's implement it really well. Let's not be limited in our ambition. We already have the biggest PrEP program in Eastern Europe. And even under the COVID pandemic, the PrEP program grew. I think this is, this shows the initiative and we should really be proud of that achievement. I think what I just really want to say is let's be confident and ambitious in our plans for PrEP. And I'm really looking forward to the next 2 or 3 days of discussion. But let's, as a result of these discussions, develop something even more ambitious and something that we can be even more proud of. Thank you very much.
Дякую, Мартін. Дякую за ваші слова.
Thank you, Martin. Thank you for your words. Thank you for your emphasizing that we should to keep in mind the experience on scaling up our program. And I would like to say that if we would manage to eliminate its overregulation, yes, it will help us in reaching our aims. And now I would like to give the floor to the CDC in Ukraine, Ezra Barzilai.
Меня слышно, да? Хорошо. Уважаемые участники и гости Второй национальной конференции по ПрЕП за пределами обычной защиты. Добрый день. Меня зовут Barzilai Ezra, я директор офиса CDC в Украине.
Beyond conventional protection, my name is Ezra Barzilai, and today I speak on behalf of PrEP in Ukraine, and for me it's a great honor to be here together with you, because it's really very interesting and very important conference. Just several years, I remember when I opened the first conference on PrEP,
Количество тех, кто интересуется этой темой, выросло в несколько раз. Я глубоко убежден, что контактная профилактика играет ключевую роль в достижении снижения новых случаев ВИЧ-инфекции в Украине и в мире там. МОЗ Украины, Центр общественного здоровья Украины, представители ключевых групп и международные доноры программы PrEP поставили себе и продолжают поддерживать очень амбициозные цели. Но достижение этих целей будет иметь решающее значение в Украине как угрозы общественному здоровью. Эти цели для нас вполне достижимы благодаря согласованным и существенно ускоренным усилиям всех участников этого процесса. В поиске ответов на угрозы и вызовы нам очень важен опыт коллег из других стран по внедрению контактной профилактики. Полагаю, что эта конференция предоставит ее участникам широкую площадку для обмена опытом, мнениями и знаниями по многим актуальным вопросам обеспечения контактной профилактики. И желаю всем участникам конференции продуктивной работы по разработке инновационных подходов внедрения контактной профилактики. Желаю успешной работы всем. Спасибо.
And I wish you very successful work. Thank you very much. Thank you very much, Ezra, for your nice welcome work. Yes, PrEP is very important in reducing the new cases. It goes without question. And now we invite Roman Galevich from UNAIDS of Ukraine.
Thank you, Natalia.
Please.
I will do my welcome words in English. Well, UNAIDS is proud to support the National PrEP Conference in Ukraine, and it is great pleasure to see that it has attracted a wide international participation to, including my fellow colleagues from UNAIDS and our sister agency, WHO. In March this year, UNAIDS has proposed an update for its fast-track strategy to end AIDS by 2030. Yesterday, the new strategy got a strong political impetus from the UN member states at the UN high-level meeting on HIV/AIDS, which is taking place these days in New York. But at the same time, yesterday, after the UN member states adopted the political declaration, many country representatives took the floor to disassociate their governments from certain provisions that, for instance, specify key populations who are at risk of HIV, like men who have sex with men, who question the validity of harm reduction approach, question the human rights-based approach, question the call to eliminate discriminative laws and norms, and so on. The good news is the government of Ukraine is not among them. From within Ukraine, the openness of the government of Ukraine to embrace new approaches and policies may not be that sharply evident, so that everyone may fully appreciate it. And the willingness to roll up PrEP, to make it an HIV prevention option available at sustainable basis at the expense of the government, is just one example, one of many, of the commitment of the government of Ukraine to end AIDS by 2030. It may appear that in the public discourse, access to HIV prevention is overshadowed by the emphasis on the 95, 95, 95 target, which rightly aims at early diagnosis of HIV, immediate start of treatment, putting patients on modern, optimized regimens to quickly suppress and maintain suppressed HIV viral load, thus reducing mortality and leading to a much desired condition, undetectable equals untransmittable. But HIV prevention remains an indispensable pillar of the new UNAIDS strategy, and pre-exposure prevention is an essential element in the combination prevention approach, which UNAIDS believes is necessary to reach the goal of ending AIDS. I believe this conference will provide another building block to roll out PrEP in Ukraine and will equip policymakers, practitioners, community activists with pertinent knowledge. And let me reassure you that the UN Joint Programme on AIDS will continue to provide technical support to boost demand for and availability of PrEP to those who are at risk of HIV infection in Ukraine. Thank you.
Роман, дякую вам за представлення і дякую за підтримку.
Thank you, Roman, for your kind words, and thank you for your efforts from the side of WHO. And we will be keep in line with the objectives that were set up yet in New York. So for us, it's very important to get it timely in order to include in our regulation. And now Andriy Klepikov is invited to take the floor.
Во-первых, хочу поздравить всех нас. Это действительно потрясающе.
I would like to congratulate all of us. This is wonderful. Such a big number of participants, 376. I don't really remember which other topic gathered such a group. Neither COVID nor other issues have ever united that number of specialists. This is really the criterion of huge success and interest to the program. I remember the day when PrEP began in the country on 17th January 2018, thanks to support of CDC, as well as interaction with partners, Alliance Global, Public Health Center, Kyiv Special Center, all the partners. Over that time of the pilot project, with 100 people in Kyiv participating, nowadays PrEP is available in every region of Ukraine. This is a huge success. The important thing is that combined approach, the leadership of medical institutions and civil society and the community, Ukraine became a model for other places. We were attended with a study tour from Belarus. We helped to launch alliance to launch the project in the Northern Macedonia in the beginning of this year with support of WHO. There is exchange on PrEP with Moldova, and that list can be extended. This conference is yet focusing on Ukraine. So what do we have? Those obstacles which existed have only partially been overcome. We cannot speak of expansion of PrEP unless we have demedicalization of PrEP. Therefore, technically, PrEP can be administered by any doctor who underwent training or certification. In reality, however, nobody does it. PrEP is yet focused on AIDS Center and IRT. With IRT, we expanded treatment to the level of mobile clinics, NGOs. I hope the conference will help us to overcome the obstacles we currently have. Indeed, it's critical because our objective in Ukraine is quite ambitious. For this year, 7,000 people. For next year, 10,500. For 2023, 13,500 on PrEP. Therefore, shall we maximize our efforts in order to analyze what of the existing practices will help to move forward? What of the best international practices must be implemented in the country? Such examples have been mentioned, including online technology, as well as the lessons on support of the program that worked under conditions of COVID pandemic, when there was home delivery as well as online consultation. Demedicalization, involvement of family doctors, also dermatology and venereology service, STD department, NGOs, community leader, as well as civil society, mobile labs will help us, the entire country, to achieve the objectives that we have. Thank you. I wish all of us a successful work. Thank you, Andriy, for your words. I would like to thank for support in PrEP implementation in the very beginning of PrEP in Ukraine. Also, I would like to thank for outline of the barriers, because this will help to develop the strategy and the interventions and the innovations that will help to overcome them and to provide for expansion of the objectives. The floor is given to head of the Coordination Council, 100% of life, Mr. Dmitro Sherebey. So, Dmitro, you have the floor. I apologize for being in the car. We just finished a meeting with the Health Ministry, and I could not physically reach my office. I could not leave the meeting. However, I would like to congratulate you on the occasion of the conference, being next to the ministry. Also, this is Igor Ikuzin, who became Deputy Minister for Health. This is improvement of quality of policy of TB, AIDS, prevention. I congratulate him with this promotion, which is logical in view of his expertise. All of the programs and all of us can be congratulated that this policy is improved quality-wise by people. This is remarkable that this conference, is his participation, makes it possible that all the ideas, all the initiatives we're going to discuss to be implemented into the real life, in the reality we are living, not the theoretical plans in 2025, 2030, and have it right now. I call everybody to the following, that all the declarations of the UN General Assembly, any high institutions in the world, to be ahead of that by uniting our efforts, that the PrEP in 2022 actually will become available under the government program, in the government package of services, and this would begin our daily life, that our plans would turn into reality before they exist in our documents that we sign, because there is life behind it, I congratulate all of us on the occasion of this event. I understand everybody have expressed their greetings. However, the politics is a future built today. Each of the organization in this conference is an opportunity. You cannot find more devoted people to the idea of stopping AIDS epidemic. Mr. Leshko, Mr. Kuzin, there are no more devoted people. Within 16 or 12 months is a window of opportunity. All the consultations and the initiatives finally will be turned into the list of the expectations and commitments we all undertake. We as an organization, people living with AIDS, with HIV, would undertake a commitment that by 2023, Ukraine should turn PrEP policy into financial policy. And actually adding this to the guidelines so that the doctors have professional liberty to operate like in the rest of the civilized countries, for the doctors to feel themselves safe at the level of a family doctor. Using this opportunity that the Deputy Minister is with us, everybody hears that our declaration should be an important commitment, even in the words, as we agree within 6 months we can reach such a result and save not the 20, not the 30, but more and lives. And the civilized world can be built earlier, and giving Ukrainians more rights to make a future safe for them. I would like to congratulate you on that occasion. I wish a productive process on the conference and even more process after it in summer, fall, and winter, that everything we have agreed about would be implemented in the real life. Thank you very much for such words, Dmitro. We have completed our welcoming session. As we can see, today we have a unique window of opportunity. As we say, it's a window of opportunity. And that window will provide for implementation of the ambitious objectives. They will not remain declarative. They will have to be implemented practically. We have a support at the higher level of leadership of the health ministry, international organizations, our partners, non-government organizations. So we don't have doubts. And we start working, and we shall start making the plans, and we shall start having innovations. So, Larissa, you have the floor. Thank you. Since the beginning of the conference, we have more participants. Therefore, I suggest to focus on the rules of the conference, that it becomes convenient for us to operate. So, dear colleagues, please check if you have rightfully registered. If you can see that you entered under the wrong name, please rename yourself. For that, could you please choose in the bookmark of participants the detailed button and the rename button. Then the conference is supported with simultaneous interpretation, so in order to use it on the panel, also please press the button and choose a convenient language. The conference employs such a format that for the participants, the mics will be off because we are 380. Even if 1 or 2 open mics, there will be noise, and this will not be convenient. Yet the feedback will be provided. Please write your questions into the chat, and we shall answer them. The speakers who will present a particular topic, we shall answer your questions. Even if some questions are not highlighted during a particular topic, after completion of each day, we have a summary. We can also highlight those issues there. And before every next day, we can discuss the previous day, and you can mention those issues. So please write your questions on the chat, and we shall answer. As far as speakers are concerned, they can manage the presentation on their own. Those speakers who will speak live with their presentations, if this is recorded, Of course, after the end of it, it will be possible to ask the questions to the speaker. The format of the conference is a plenary session. The third day of the conference is the panel discussion with representatives of the civil society. Therefore, dear colleagues, please join us on that session. By results of every day, we shall have a summary that will generally be included into the resolution. And as the colleague said before, indeed, those should not be just declarations. Those questions we're going to raise on that conference can be further implemented in the work. So, dear colleagues, everybody who has registered and entered under the right name, after the end of the conference, you'll be able to have certificates. As I said, Natalia, if you would like to add something, please do that. So, Larissa, I'm watching the clock, and I'm eager to give the floor to the first speaker. The first speaker will speak about the importance of PrEP for achievement of global objectives, about reduction of new cases of infection. I invite the consultant of the Regional Bureau of WHO, Yanis Vangalis, epidemiologist. Yanis is epidemiologist, having vast experience of clinical use and implementation of programs of PrEP in other countries. Also, Yanis actively supports and works with Ukrainian colleagues about fulfillment of our national proceedings and objectives of PrEP. Yanis has been in Ukraine in 2018. He took part in Odessa conference in 2020. Yanis made expert evaluation of the program of PrEP implementation in Ukraine, and also he highly appreciated Ukraine's achievements in the domain of PrEP. So, Yanis, you have the floor.
Thank you very much, Natalia, and good morning, good afternoon, good evening, everybody. It took me a while. Thank you, Larissa, for telling us how to change my name. I'm actually maybe in the program as Ioannis Gonzalez, but my last name is Hodges Mamelidzis, but you can just all call me Yanis. And again, real privilege to be part of this meeting and to be supporting the efforts of PHC and partners to put on this conference. And also just trying to kind of echo Martin Donohue's earlier comments, opening comments on the need to make sure that over the next 3 days, we're taking the experiences both within the country and international practices on rollout of PrEP and thinking about being even more ambitious in terms of our actual strategy and plan in scaling PrEP rapidly over the next few months and next few years, because we really do have the tool to be able to put a dent on new HIV infections. And so that's why we're all here over the next few days. And again, very, very, very humbled to be part of this meeting. So I will share my slides, and hopefully you can all hear me well. And Natalia, just a thumbs up if you can see my slides. Beautiful. Thank you very much. So we have a very exciting line of speakers over the next 3 days. So I'm going to be doing a little bit of scene setting. And I've been asked to present on the role, relevance of PrEP in achieving those global goals and reducing new HIV infections. I've again have had the privilege of visiting Ukraine and being part of in-person missions, and last year working with the WHO country office through a virtual consultation where we came up with 12 concrete recommendations on how to scale up PrEP to PHC. And our colleague Darren made note of those 12 recommendations. They're actually right here, and we'll articulate a few of those and really can get into those over the next 3 days. So let's get going. First off, no financials of conflicts of interest to declare on my end. So I sort of start our discussion with thinking about two things we need to reflect on. First, we need to think about what I call the decade of PrEP. So we've moved from the science to actually developing global policy, WHO policy, and then starting to implement, at the country level. And then I think the next thing in terms of sort of our mental framework has to be about how do we transition all of that into thinking about models of PrEP care, and how to get those models of PrEP care made available, scaled up rapidly. And all this means nothing if we don't think about equity, especially for key populations. And this is incredibly relevant in the context of Ukraine. But before I moved on to PrEP, I welcome you to all read this very wonderful article published last week by Chris Baer, reflecting actually on the 4 decades of the HIV/AIDS on our planet. And I think it's sort of really well articulating the struggles, successes that we as a community have managed to address. But I sort of also, to Martin Donohue's point in his opening remarks, it was really thinking about the things that we've not done so well in getting ART to populations, as you know, specifically on that point about over-regulating. And other colleagues in their opening remarks talked about simplification of PrEP. I think there are the lessons that have been learned from 4 decades of in the HIV/AIDS world. So I think that's a point of reflection. And again, I welcome you to read this this very nice article. So what about this decade of PrEP? It really, I'd say it all really started with the first report of a randomized clinical trial on the clinical trial efficacy of oral PrEP. This is the seminal study, IPREX, multi-country study, and this was published in late December of 2010 by Bob Grant and colleagues. First demonstrating that taking a pill every single day was both safe and highly efficacious in reducing the risk of HIV acquisition. So that's the first study then. Since then, we've had extensive clinical research in other populations, in addition to men who have sex with men. We have other products, other modalities in biomedical prevention that have been studied. I want to sort of also draw your attention to 2 studies. They're in the sort of the light blue circle. This is the dapivirine vaginal ring that has been actually tested in 2 independent clinical trials in sub-Saharan Africa, showed moderate efficacy. But given data from open label extension studies, WHO actually this year has recommended the use of dapivirine ring in addition to oral PrEP. So there's a lot that's sort of in our portfolio, in sort of the near or medium term future. And we have a colleague from AVAC that on Friday will talk about these sort of different modalities. But really, what we have right now is oral PrEP, and it's registered, it's available, it's being rolled out. So even though we really much are into the notion of choice and other options, as we really try to put a dent on HIV infections, we do have this tool that really can drive down HIV incidence right now. So also, I just want to articulate that when we look at people who actively take drug, PrEP is up to 99% effective in preventing HIV acquisition. So it's on this slide. I say this often. PrEP is the closest thing we have to an HIV vaccine, and it is currently the most effective biomedical form of HIV prevention. And as I noted, there's other products in the pipeline. WHO recommends TDF, tenofovir-containing oral PrEP, and that gives countries the flexibility to actually choose between TDF-FTC or TDF-lamivudine. Both of these combinations were included in WHO's essential medicines list in 2017, and then again updated in 2019. I also have a link down there to our WHO PrEP implementation guidance from 2017, which is also currently being updated. We are in the era of generic drugs. They are registered, available. Drug is not the only thing that has a budget impact in a country's PrEP program. We really need to think about the human resource allocation in supporting a robust PrEP program. Well, that said, It's also important to note that as WHO encourages countries to think about how to include PrEP and reimburse PrEP within their national health systems, we also need to think about how access can also be enabled through the ability for people to purchase their own PrEP. So there is a willingness to pay for PrEP when we ask communities, and that should also be enabled. So when thinking again about regulation and simplifying policy, this is people's ability to purchase PrEP and made accessible should be something that be considered at the country level. As noted earlier this year, WHO moved on to also recommend the Dipivirine vaginal ring as an additional HIV prevention choice for women at substantial HIV risk. Data from WHO earlier this year really looks at the uptake in PrEP utilization by WHO regions. 2012, so thinking about the decade of PrEP, 2012 marked when the US FDA approved Truvada, tenofovir and tricidabine, in having a PrEP indication, so for PrEP. And so you had minimal utilization in the United States. And for the next few years, that sort of blue bar there is really only the United States. In 2015, WHO moved to recommend PrEP for any person at substantial risk for HIV. And so what that did was it enabled countries to think about how to put PrEP into their national ARV guidelines or create their own standalone PrEP guidance. And then beyond policy, you had to think about how to finance PrEP and how actually get PrEP into becoming a program. And so then we start seeing from 2016 and then on to 2019, other regions, start implementing PrEP. Although, in my own viewpoint, by the end of 2019, we had over 600,000 people, and this is an underestimate, of people who had used PrEP. Nonetheless, obviously, there is an unmet need globally, and both in the WHO European region and the Ukraine. So, again, back to Martin's point, we really need to be ambitious and effective. We are grappling with vaccine inequity, similar paradigm to ART and PrEP. But that said, we know people are going to be are engaging in sexual activity, and so PrEP most definitely is an essential service, and it should be maintained and strengthened even through a pandemic. And I think that's and as colleagues commented before me, on a good job in ensuring that the PrEP services that exist are maintained and people can access their PrEP through creative ways of service delivery. A few weeks ago at the World Health Assembly, WHO member states have been called to provide input into the next global health sector strategies for HIV, viral, hepatitis, and STIs. Here, I just have the link to actually a survey that all participants at this conference are welcome to provide input into the strategy. And I really welcome you all to actually, be quite articulate about what you think should be included in the strategy around PrEP, and very much that to be articulated in our next global health sector strategy. WHO is in the business of making guidelines, but also ensuring that we are developing pragmatic tools and ensuring that we're educating, informing our providers. So there's a wonderful collaboration with JPIGO, and there's an online platform to train clinicians. So as we think about rolling out PrEP in Ukraine to non-specialists and to family medicine clinicians and to dermatologists, we do have tools that are already available that really can be utilized to do that very critical training of providers. PrEP is a pill that is taken every single day for any population during a period of risk. However, a very important piece of guidance from WHO came out in 2019, specific to men who have sex with men. It's evidence-based, and it's the use of what we call 211 event-driven PrEP, or on-demand. And so this guidance really allows for people that have less frequent sex or can plan their sex and are able to basically take a very short course of PrEP medicines around one sexual act. And so this here sort of shows you that dosing strategy. It's 2 pills that are taken 2 to 24 hours before sex, and then a single tablet 24 hours after that double dose, and then another pill 48 hours after that double dose. It's really, it's efficacious and demonstrated to be efficacious only in men who have sex with men. It's recommended by WHO. And it's based on our virtual consultation mission with PHC and partners last year at the country office. We really welcome the decision by PHC to incorporate this as an additional dosing option that's being offered to MSM in Ukraine. So that is, again, an enabling factor to scale up PrEP. So quickly, I will move to just talking about the models of PrEP care. And all this will be sort of well presented by presenters coming up after me today and tomorrow and the next day. So I would like to just argue for models of PrEP care that should be actually creative. We want these models of care to be person-centered. Even though we're going for a public health approach to drive down HIV infections, we really need to think about being person-centered. And again, I really need to underscore the word equitable. DSD, differentiated service delivery, is really the way to move forward. At the high-level meeting over the past week, this has been really a hallmark of discussions, both to minimize the treatment gap and also minimize the prevention gap. And this, if we can do this, we really can have epidemic control. So as I say, differentiated care equals different strokes for different folks. Something that Martin and I are keen on is ensuring that we don't get stuck in this demonstration project mindset or having an access trial. Even though access trials for PrEP, and they will be described over the course over the next few days in a number of countries, have been very important in getting PrEP made available at a first phase. But we really need to think about how we move away from those access trials quickly into like wider access. And here I just have an example. I am in Switzerland currently, and there's just a wonderful online platform, that there is often updated and tells you exactly how many people have sort of are actually enrolled on PrEP in the country, and where you can actually find PrEP in your nearest center. So this type of online platform is actually very pragmatic and very useful for people who may benefit from PrEP. Another point that will come up over the course of the next few days is this notion of effective use. So it's a term really coined by Dr. Nitaya in Thailand, as I understand it, and it's really thinking about PrEP should be used, at the right time, and that. And that's sort of going back to WHO recommending 211 event-driven PrEP. That's really been an important step in prevention, because not everybody is at the highest level of risk of HIV infection. And some people are at more moderate levels of risk. And some people are currently not at risk for HIV. They may enter a weekend of risk or a month of risk. And so this concept of effective use is really kind of becoming much more sort of prominent in our discussions. This has implications for the way donors and programmatic managers really think about continuity of PrEP. So somebody can start PrEP and stop PrEP, and that is totally fine if after they stop PrEP, there really is no risk for HIV. So this was really mentioned in the opening remarks, and something that WHO has made a specific recommendation to PHC. It's really thinking about how we take the PrEP clinic online. So virtual services. There's a wonderful document published by the National Coalition of STD Directors in the United States recently, and it's looking at COVID-19's impact on PrEP and PEP sexual health services. In there are very concrete recommendations and on how PrEP being offered through telemedicine actually can increase PrEP coverage. And the other thing that we need to think about in Ukraine is around self-sampling, self-testing. There was a point that was mentioned in the opening around creative, smart ways of distribution and pickup points for PrEP. And that's really the way forward. And that's something that we need to be working with partners very actively in the next few weeks and months. I just want to highlight here based on the latest global AIDS strategy by UNAIDS. There's very specific coverage targets for the different key populations on PrEP use based on different strata of risk. Some can argue that these are ambitious, others can argue that these are not ambitious, but I think it's a topic of discussion for the next few days. And we do have our UNAIDS colleague, Keith Sabin, that will be presenting on PrEP targets. As I conclude my talk, I really go back to a paper from 5 years ago by Bob Grant. This is the lead investigator of that initial study, which I mentioned earlier in my talk. And so what can PrEP do? So obviously, it is the tool that we have available that really can complement all the other efforts in terms of quick initiation of ART, expanded HIV testing, ensuring we have the enabling environment for people to come into services. And with PrEP, it really can all those together can end HIV. At the individual level, let's not forget, as policymakers, as donors, as providers, as people in the community, let's not underestimate the individual benefit beyond preventing HIV acquisition, which I list here. And these are important outcomes to be documented and highlighted as we implement PrEP and scale up PrEP in Ukraine. And these should be documented and also better understood at the clinical level. It's reducing fear, anxiety during sex. It's reducing HIV stigma. It's enhancing pleasure, which is an element of sexual and reproductive health. Stabilizing couples and serodiscordant couples. PrEP is a vehicle for safer conception. People can feel empowered when they're taking PrEP. And making sure that people are protected during what is a term called seasons of risk. Or now that term has evolved a little bit into effective use, I would say. So I just want to also for you to reflect on these points on what PrEP can do both at a public health level and individual level. And on that, I conclude my talk. I want to dedicate this talk to our beloved colleague, Dr. Jana from Calcutta, India, who passed away a few weeks ago due to COVID-19, PrEP champion for key populations and specifically for sex workers, and really the architect of all this wonderful gold standard work in India that has really inspired sex worker programming in the rest of the world. And with that, I thank you for the opportunity to present.
Дякуємо, Яніс, за гарну змістовну презентацію.
Thank you very much, Yanis, for your good presentation. I would like to stress upon that you really mentioned very important things, that we have to be creative and accessible on implementing PrEP, and we have to take it in mind when implementing PrEP. We have questions in chat, so if, I would like to read the questions from chat to you. First is from Anna Kovan. Yanis, how do you think, when can we switch from pills or tablets to other forms of PrEP, like injection PrEP or vaginal ring? Thank you. When we can switch to these new forms?
Thank you for the question. I just want so what's happening right now is WHO recommends oral PrEP, TDF-FTC, TDF-3TC It also recommends TDF monotherapy, but we really are not encouraging countries to go for the monotherapy. That said, we have those long-acting cabotegravir has been shown to be highly efficacious in 2 independent randomized clinical trials. The US is considering regulatory approval of long-acting cabotegravir, and WHO headquarters is in discussions in developing guidance for long-acting cabotegravir. I suspect that will come out at some point in 2022 is my hypothesis, and so in terms of that being available at the country level, I don't think it would come at any point by the end of maybe 2022, 2023. We do, however, need to think about how we're offering oral PrEP at clinical sites, and again, thinking about teleprep, it will impact how we deliver some of these other products. For long-acting cabotegravir, one has to come every 2 months to get the injectable. And so that's been shown to be effective in both MSM transgender women and also cisgender women. Regarding the dapivirine vaginal ring, even though the focus of it is really in sub-Saharan Africa, in generalized epidemics, there is no reason why we should not be having a discussion with partners on the role of dapivirine ring for cisgender women in Ukraine, but to complement oral PrEP. But it's that should be also likely available in countries at some point by 2022. Thank you.
Дякую, Яніс. Я би ще хотіла зачитати один коментар, який в нас є від Gus Gaines.
Thank you, Yanis. And from Gus Gaines, we have the comment that it's very important for us to switch from just the trials to, to prevent the risk factors in key populations, just to avoid stigma. And it will it may happen that PrEP cannot be administered, in particular when we promote PrEP in workers as gender women or transgender women. It will create some stigma, and so we can do that. The health physician may take the decision of administering the PrEP when he sees really any person whatever the gender is at risk. And now, thank you, Yanis. Thank you very much. Please stay with us online. And the next presentation is on updates of CDC guideline. Namely, we have the expert of monitoring HIV infection, the expert on HIV and airborne infection, ECDC, European Center for Disease Control and Prevention, Timur Nouri, who is directing those programs in Asia.
Hello, everyone. My name is Timur Nouri, and I work at the European Center for Disease Prevention and Control, and I will give you a short talk on PrEP implementation in Europe. So this is the outline of my presentation. I will talk about PrEP in the context of the SDGs, the Sustainable Development Goals, focus most of my talk on status of PrEP implementation in Europe, and say a few words about some ECDC guidance on PrEP, some operational guidance. But I just want to start with some epidemiology. So this shows you that 2.2 million people are currently living with HIV in the WHO European region, and this is data from 2018. So we do joint surveillance with WHO Euro and publish this data. Now, in 2018, we estimated that approximately 142,000 people were diagnosed with HIV in this wider European region, but it's very different depending on which parts of the region we look at. So in the western parts of the region, 16% of all diagnosed cases occurred. In the center, 5%, and in the eastern parts of the region, almost 80% of all of these 142,000 occurred. So the burden of HIV in our region is, of course, in the eastern parts of the region. And you see in the bubbles the rates per 100,000 population, again, very much higher in the eastern parts of the region. If we look at HIV transmission risk patterns by subregion as well, they differ quite significantly. In the West and in the center, they're quite similar. So approximately 50% of all diagnosed cases occur among men who have sex with men, followed by heterosexual contact, and only 4% among injecting drug users. Whereas in the eastern parts of the region, you see here that heterosexual contact and injecting drug use account for the majority of diagnosed cases, followed by only 5% among men who have sex with men. The issue of migration is also very different, whereas almost half of all diagnosed cases occur among people who are born abroad in the western parts of the region. That drops to 10% in the center and only 1% in the eastern parts of the region. Okay, so moving on to the SDGs. I think these are really important because it puts PrEP into the context. So, you know, goal 3 is about health, and goal 3.3 is where we talk about ending AIDS by 2030. Now, UNAIDS have defined what it means to end AIDS, and they say here, as you see here on the right-hand side, that by 2030, we should have 0 new infections, 0 deaths, and 0 discrimination. And on the left-hand side, by 2020, we need to be reaching these targets. Now, PrEP fits into this target around reducing HIV infections. So there is a global PrEP target that by 2020, at least 3 million people globally should be on PrEP. But we don't have a regional target, and we're hoping that UNAIDS will come up with a regional specific target for our, so that will help us move forward. ECDC publishes a brief around PrEP every year. This is from November 2019. I'm going to show you some of the data from that and also some updated data. So this shows you a map of the status of formal PrEP implementation in Europe as of October in 2020. And there's a clear west to east gradient, whereas the dark green countries in the west shows you where PrEP is nationally available and fully reimbursed. You see a lighter green color where we have ongoing pilot and research projects. Ukraine is one of those examples. And in very light green where countries are making PrEP available, generic PrEP, where it's not fully reimbursed, but it can cost anywhere between 30 and 60 euros per month. And as you see in the eastern parts of the region where PrEP is not formally implemented whatsoever. This may have this map may have changed slightly over the past year, and we're about to release new data, and I'll get back to you on that issue. Now, we ask governments, why aren't you implementing PrEP? What is limiting you or preventing from implementation of PrEP? And historically, the cost of PrEP itself has been the main barrier. But more and more, we see this issue of limited technical capacity and the cost of service delivery as two major issues. So how do we actually implement PrEP? In what setting? Those are more and more important issues going forward. This is new unpublished data looking at the eligibility of PrEP, different populations in Europe and Central Asia. And not surprisingly, you see that gay men and other men who have sex with men is the key population in Europe where most countries are making PrEP eligible to, followed by transgender people, zero-discordant couples, sex workers, etc., etc. What's important to say here is that countries like France, UK, Norway, where PrEP has been implemented for a long time, they have great difficulty in attracting people to start PrEP other than men who have sex with men. So it's very difficult for them to get women, transgender, migrants, etc., into these PrEP programs. So that's a real challenge that I think you need to think about going forward, how to attract other groups other than men who have sex with men. This is also new data looking at the settings in which PrEP is available across our region. So PrEP is available in public facilities, research settings, private providers, the internet, and through other means. And if we look at these private facilities, only focus on that, you see here that more than 50% of countries provide PrEP through infectious disease clinics, 20% through sexual health clinics, 15% through primary care, and a few percentage points for unspecified. So this is something we're going to look into a bit more going forward. This shows you the number of receiving PrEP in the last 12 months per 100,000 of the adult population in 2020. The blue bar shows you those who are receiving PrEP at least once, and the red square shows you those who are receiving PrEP for the first time. And I think what's really important to show here, rather than focus on the numbers, is the relationship between the blue bars and the red dots. So the relationship here shows you that out of those receiving PrEP at least once, the blue bars, the vast majority are receiving it for the first time in the countries that have data. So this tells us that scale up of PrEP is happening now. A rapid scale up in countries is happening now. So that's something positive. We're trying to improve these numbers going forward, but that is a really important message, I think. We have tried to estimate what the PrEP gap is in Europe when it comes to men who have sex with men. We published this important paper, and I'll show you some of the results from that paper. So we collaborated with the EMIS study, the European Men Who Have Sex with Men Internet Survey. And this is data showing you, the green dots here show you the percentage of EMIS respondents who are currently taking PrEP daily or on demand in the participating countries in our region. These red dots shows you the number of respondents who would be very likely to use PrEP if it was available to them. So the green dots is basically how many people are getting PrEP, and the red dots are showing you how the demand side, how many would want PrEP if it was available to them. And the difference between those two is the so-called gap in these countries. So the biggest gap occurs in Russia, and the smallest gap on the right-hand side in Portugal. In the EU, 3.2% of the respondents said they were currently taking PrEP, but more than 20% said they would take it if it was available to them. So the estimated PrEP gap in the EU is 17%. And zooming in now on Ukraine, you see that only 0.7% of respondents were currently taking PrEP, but more than 31%, almost 32% said they would be using PrEP if it was available to them. So that PrEP gap is 31%, almost twice the gap as it is in the general population in the EU when it comes to men who have sex with men. So big challenges ahead. So for the EU countries where we have full data, we estimate that approximately 500,000 people, or sorry, 500,000 men who have sex with men who want to need PrEP in the EU, we're not accessing it. That number is going to be bigger if we look in the eastern parts. This is only for the EU. So the longer the delay in access to PrEP for these men, the more HIV infections will occur among them. So we really need to be scaling up PrEP quickly. Okay, moving towards the end of my presentation is going into this operational guidance on PrEP, which is not in development, which is actually being published. So this operational guidance on PrEP, we're not looking here on the effectiveness of PrEP, etc. It's really trying to support countries on how to implement PrEP instead. So we're trying to develop some minimum standards and key principles for PrEP service delivery. We worked on a PrEP monitoring tool in this guidance. We were asked to produce a policy brief, a 2-page document to make the case for PrEP. Countries asked us they needed the support to persuade their policymakers. And also we have some country case studies, and I'll get back to you on those in a few slides. So this was published in March, so it's very relevant for you, and I think you should look at this if you want to look at how European countries are working on implementing a PrEP. So these are the 10 core principles of an effective PrEP program. These have been identified through the literature review, but also from a large, extensive expert panel. And these are the 10 principles that we identified. And in the guidance for each of these 10 principles, we describe why these principles are of real importance. We talk about some of the minimum standards for delivery are presented among these 10 of all these 10 principles. And we also categorize these 10 principles as being relevant for pre-PrEP programs, countries that haven't actually started yet, new PrEP programs, probably Ukraine would fit into this category, and established PrEP programs. So depending on where you are, you will have different standards. If you're a pre-PrEP program, your standards should be much lower than it is for an established PrEP program. I'm not going to go through all these 10 principles, but I just want to show you one principle for a new PrEP program, which I think where probably Ukraine fits into. And this looks at PrEP awareness and demand creation. So in terms of the quality statements, we make the statement here that development and implement strategies which continue to raise awareness and create demand for PrEP, okay? And the minimum standard for that is that all groups identified as being at increased need of PrEP are provided with accessible information about PrEP. So look in your country. Have you identified the people that need PrEP, and are you reaching out to them about the information around PrEP? The second quality statement at the bottom, you need to know what the size is. You need to estimate the demand for PrEP among these key populations. And the minimum standard is that you should have identified some sort of tool in your country that can be used to estimate what the demand for PrEP is. So we're going through all 10 principles in this way for different categories of programs. So that's what it looks like. As I said, we've accompanying this guidance with 17 country case studies, and these are really, really good case studies showing you where countries identify what the main challenges are for implementing PrEP in their countries, what the main challenges are, what they would do differently now that they've done this for a couple of years, what advice they would give to other countries that are considering implementing PrEP. So really rich case studies that I encourage you to look at it. And finally, as I said, we really needed to spend more time on developing a standardized monitoring tool for PrEP. So that's a project that's ongoing now, which will be published in the beginning of next year, where we have a more detailed guidance for which indicators to collect. So to conclude, formal PrEP rollout has been slow, especially in the eastern parts of Europe and Central Asia. Although PrEP rollout is increasing, there is evidence of significant informal PrEP use across European countries. Estimated this gap to be 500,000 MSM who want and need PrEP in the EU are not accessing it, and that number is going to be bigger in the eastern parts of the region. And clearly there is an implementation gap when it comes to women, transgender people, migrants, PWID, sex workers, etc., where we're not reaching them. We're mainly focusing in the western parts of the region among who have sex with men, but we are struggling to reach other populations. And as I said, we've developed this operational guidance that I hope would help you moving forward. So I want to stop there. Thank some colleagues that have worked with us over the years, and be happy to take some questions. Thank you very much.
Дякую, Тимур, за таку гарну презентацію.
Thank you very much, Timur, for this very interesting presentation. I would like to stress upon that we are somehow delayed with hours. So Timur mentioned that the PrEP should be available not only to MSM, but very competent PrEP that can be used for migrants. And now we switch to another topic. This is the rapid expansion of the PrEP program in New South Wales of Australia, and the work is given to Irina Zablotska from Sydney University. Irina implemented PrEP in Australia, and it would be very interesting to listen to her experience when she started just with several clients, but now this number is thousands of people. And we invite Irina to share.
Добрий день, шановні колеги. Дякую за запрошення розповісти про розгортання ПрЕПу в Австралії. I will share some lessons and discuss challenges of our current PrEP implementation. Australia is a country of nearly 26 million people, which is about 60% of the population of Ukraine. About 1/3 of our population lives in the state of New South Wales, including the capital city, Sydney, which is the largest city in Australia. According to the last surveillance data, by the end of 2019, we accumulated about 29,000 HIV diagnoses. In the last 10-year period prior to PrEP implementation, up to 2015, HIV infections were on the rise and stable. The decline that followed since 2016 is largely attributed to the Australian HIV prevention strategy, which, among other measures, embraced biomedical HIV prevention, including PrEP. The results of our PrEP rollout, mainly to our key populations of MSM, can be evident in the figure on the slide. As soon as Truvada was approved in Australia for PrEP indication, and the implementation studies started, HIV infections dropped significantly by about 40%. PrEP subsidy and unrestricted prescribing of PrEP started in April 2018. It certainly improved access to PrEP to the people, with a relatively small copayment of $36, which is approximately 1% of minimum monthly wages. Public access and subsidy, however, did not additionally improve the rate of decline in HIV diagnosis. HIV prevention in Australia historically targeted high-risk key population groups, mainly high-risk MSM. Therefore, PrEP implementation mainly targeted this population group. In initial stages, we focused on high-risk MSM and used strict eligibility criteria to identify them. These criteria were based on the local evidence about our HIV epidemic, which showed the following groups of men to be at high risk of HIV infection: those having condomless anal intercourse with their HIV-positive regular partners, or having receptive condomless sex with any casual partner of HIV-positive or unknown status, as well as men having STIs and or using methamphetamine for sex. In the initial stages of PrEP implementation, prescribing was limited to specifically licensed HIV and sexual health physicians in public sexual health and HIV clinics and large private practices specializing in services for men who have sex with men. The first demonstration projects started in late 2014 and were limited to a few hundred MSM. They were particularly helpful in ascertaining that healthy MSM can maintain high adherence to PrEP and stay HIV negative. Demonstration Project Prelude in New South Wales is particularly a study of importance, as it developed eligibility criteria for PrEP. These criteria were adopted nationally and provided foundation to our PrEP prescribing guidance. These criteria were very specific and evidence-based. Using these criteria and demographic indicators from the Australian Bureau of Statistics and Behavioural Surveillance, we were able to estimate PrEP need in each Australian state and nationally. According to these estimates, approximately 3,700 MSM at high risk for HIV would require access to PrEP in New South Wales alone. This access was made available via EPIC New South Wales project, which started in March 2016. EPIC New South Wales was an observational study of daily oral PrEP. Originally planned for 3,700 participants, followed for 1 year, the study was expanded to provide PrEP to all eligible New South Wales participants. And it was also extended in follow-up to April 2018. Between March 2016 and April 2018, the study dispensed PrEP to nearly 10,000 participants, 98% of them MSM or bisexual men. And we followed them until March of 2019. The study is probably the first of its kind internationally. It was made possible because our national HIV strategy at the time embraced PrEP. Prior demonstration studies led to the development of the national PrEP guidelines and formulated very clear eligibility criteria for PrEP. To see the immediate effect of HIV diagnosis, we planned a rapid and wild rollout via a network of public and private clinics across urban and rural areas so that people can access PrEP easily where they live. A big advantage was our ability to link PrEP users, their medical records, with HIV and STI registries so that we could calculate the direct effect of PrEP use on HIV diagnosis. The government partnership, the government sponsorship of PrEP, making it free for PrEP users was vital for this trial. And community participation, leadership, and promotion of PrEP throughout the project helped to generate the demand. PrEP demand exceeded our expectations, and it grew exponentially over time. HIV incidence in the study was low. Mean medication possession ratio was quite high at 93%, it, however, declined by 1/3 from the first to the last quarter of the study follow-up. There were altogether 30 seroconversions, and factors associated with seroconversion in the study were younger age, living in the postcode with fewer gay men, possibly because of access to gay-friendly GP services. Also at higher risk were men reporting more risk behaviors at enrollment and having a medication in the possession less than 60% of the follow-up time. In the final year of follow-up, when PrEP was mostly purchased rather than provided free by the study, HIV incidence remained low, but it increased more than 5 times compared to the first year of the study. There were some other challenges as well. As you can see on the slide, those who were born not in Australia, particularly if they arrived to Australia recently, benefited from PrEP less. The rate of decline in HIV diagnosis in this group, if you can follow the red line, was slower. The reason for this was complex. Recently arrived overseas-born MSM may have limited resources to pay for PrEP, no Medicare coverage. Additionally, language and cultural factors may prevent them from using sexual health services. Since PrEP first became available through the Pharmaceutical Benefits Scheme in April 2018, and by mid-2020, recently nearly 38,000 of individuals were dispensed subsidized PrEP, but only 2/3 appear to report recent PrEP use that is maintain PrEP adherence. COVID-19 pandemic had further effect on PrEP use. In the 3 months to June 2020, this is the time of COVID lockdown in New South Wales. The number initiating PrEP fell by 45%, and adherence to PrEP also dropped. COVID-19 certainly had an effect on our PrEP users. In our clinic-based survey of sexually active MSM, COVID-19 restrictions were associated with having fewer casual sex partners, decreased physical sexual activity, and reduced drug use, which you can see on the slide. However, these changes reverted, at least to some extent, in a matter of a very short time, over 6 months. After the restrictions were relaxed. Meanwhile, PrEP use changed significantly. 1/3 of our PrEP users stopped taking PrEP during the COVID pandemic, and about 30% of those who continued using it switched to on-demand PrEP. The predominant majority of our PrEP clients in the clinics remained engaged with health services, but their access to health services, physical access to health services, was significantly affected. It is to be seen whether that effect translates in HIV diagnosis in the future. It is also to be seen whether all MSM will be able to maintain regular PrEP follow-up and ideal PrEP adherence, particularly under the circumstances of stress, such as we have seen during the COVID pandemic. This is something that we need to keep an eye on. So what made the Australian PrEP implementation successful in this is the combination of several factors. You can call it a marriage of community advocacy, commitment of the government, consensus of the health sector, and strong evidence base for PrEP guidance and monitoring of PrEP use. These factors made our PrEP rolling. In conclusion, we have learned thus far that PrEP rollout signifies a shift in HIV prevention from community to clinical settings. When it is widely available, a substantial number of prescribers, particularly general practitioners, need to join HIV prevention forces. New prescribers may experience challenges. Unfamiliar with HIV and PrEP prescribing and PrEP guidelines, they might experience challenges in serving the populations at need. Little expertise of working with MSM and possibly other high-risk groups will be a challenge for general practitioners. The partnership across the HIV sector is key to expansion of PrEP prescribing, and each member of that partnership brings a specific expertise and resources to the table. And the latest events, the COVID-19 pandemic, highlights that both resources and preparedness are needed to be able to withstand the shock and maintain the gains in HIV prevention. Thank you for being able to share these experiences with you today.
Пані Ірино, дуже дякуємо за таку чудову змістовну...
Rina, thank you very much for this contentful presentation of the experience of Australia. We have a comment in the chat that indeed the experience of Australia, which is not over-regulated and very well implemented, it's worthwhile using it also in Ukraine. The sound has disappeared for some reason. I have lost the sound. And the government sector and the advocacy and the access to services that promotes implementation of pre-exposure prophylaxis and reduction of the new cases. Thank you very much for your presentation and for your experience. Maybe, Natalia, you will have a question or comments. So, Larissa, I'm gathering the comments. And as we still have 15 minutes before the break, I suggest that we move to the next presentation. Maybe we can save some time to address the issues and also to discuss the comments, because we have very good comments from WHO office, Yanis Chernyshov, and different participants, which is about implementation, and those issues also about implementation of PrEP for injection drug users. Therefore, I suggest, if you don't mind, that we move to the next presentation.
Thank you very much for having me.
Дуже дякую.
We really appreciate your experience and your time. Thank you. І, колеги, зараз час перейти до впровадження програми PrEP в Україні. Той досвід,
Now we move to PrEP implementation in Ukraine, the experience possessed by our domestic colleagues. We shall have a presentation of PrEP in Ukraine. Larissa, head of the Department for Coordination of the Program of Diagnostics and Treatment of HIV Center of Public Health of the Ministry of Health. Larissa is an infectionist physician, having vast clinical experience in treatment of HIV. Larissa was head of the Department on Neuroinfection of the Institute of Epidemiology and Contagious Diseases, named after Gromashevsky of the Academy of Medical Science of Ukraine. Larissa is a participant of quite many technical working groups, for writing the protocols and standards for providing support. And in addition to that, Larissa has successful experience of fast response and modification of HIV programs during COVID, which helps to keep our patients on treatment of HIV AIDS. So you have the floor. Thank you very much indeed. Can you see my presentation? Yes, that's wonderful. The experience of implementation of pre-exposure prophylaxis in Ukraine, Center of Public Health is a national structure which coordinates planning and inspection of the program of pre-exposure prophylaxis, gathering data, summarization of data, development of regulatory framework, and also regulating farm management of the drugs for pre-exposure prophylaxis is involved in training and mentorship, promotion of pre-exposure prophylactic PrEP, monitoring and evaluation. PrEP, all that cannot be unilaterally organized. This all happens in partnership, support, and interaction. Today, it was mentioned more than once, the issues that were about the regulatory framework and regulatory norms. We cannot say that we are behind or if there is any substantial gaps, so there are things to work on. Therefore, in 2019, the issue of pre-exposure prophylaxis were included into the state strategy in the field of countering HIV/AIDS, TB, and viral hepatitis before 2030. And we also expect that the issues and indicators of pre-exposure prophylaxis also be part of the plan for fulfillment of the strategy. In the year 2019, clinical protocols, there was a question to were included of PrEP in February 2021. The standard of PrEP is more up to date in line with the recommendations of CDC and the World Health Organization. Those changes that we need to do is legislative change because the law of Ukraine on HIV/AIDS was written in the times when nobody knew of PrEP, and in order to move forward more freely and more appropriately on the legislative level, we are planning by the end of this year to make relevant changes also in the law of Ukraine. Today and tomorrow and on the third day, I believe we shall remember more than once those indicators and the numbers and the data that we had in the beginning of implementation of PrEP, as well as the plans for the future. Currently, that history is not that big, it's 2018, and yet this is a time when for the first time in Ukraine they began to implement pre-exposure prophylaxis. Today it was mentioned it was a pilot project at the level of the city of Kiev with support of CDC by Public Health Alliance. And that was the starting point of introduction of the drugs for pre-exposure prophylaxis when we had such an opportunity. Of course, the civil society has a big driving force in quite many directions, and PrEP is not an exception. I think that with all these pilots in 2017, if the political national will and the will of the partners and the willingness to work in that direction, those results that we have within 2019 would be difficult to assess. Speaking of the uniqueness of the clients, over that period, 2018-2019, more than 4,000 unique clients have received services of pre-exposure prophylaxis. And also today, we mentioned information technology, registration and analysis of data. Also, we can say that this data can be received by a medical information system. This can be adopted by a medical and information system. The plans for 2020, 2021 have been mentioned today. They are quite ambitious. If you compare it to those ambitious plans, when about the profile of clients, our clients have pre-exposure prophylaxis in the country. In most cases, men 78%. And also, when talking about who of the key groups, those are men having sex with men. There was a question on the chat and the comments about expansion among the partners. Of course, this is a direction that must be developed. Also, we believe that year 2021, 2022 will be the period with more active implementation of pre-exposure prophylaxis among the other key groups. key populations. We have mentioned the regulatory framework. I would like to say that in the beginning of 2019, it was one scheme of pre-exposure prophylaxis. In 2021. A quick update of the recommendations worldwide and also in Ukraine. It's possible to use and implement pre-exposure prophylaxis upon the need. Speaking of the geography of pre-exposure prophylaxis in Ukraine, nowadays, those are major cities. The blue color marks the territories with the largest number of healthcare institutions providing services of pre-exposure prophylaxis. And also, this is the challenge and the step which must be made for further decentralization. And also, as healthcare institutions, we understand that with no efficient decentralization at the level of the family doctor, it's very difficult to fulfill those ambitious targets that we have before ourselves. Therefore, there are plans and there is a need to develop, as it is developed, allowed now by the regulatory framework, not only in big cities, not only in major healthcare institutions, also in smaller ones, and also expansion to cover the primary link and at the community level. Of course, without promotion of pre-exposure prophylaxis, it would be difficult to achieve those objectives. Therefore, the process was simultaneous. If you remember the year 2018, that was a publication which was on Facebook by Andrei Chernyshov, who was a leader, who is a leader of the MSM community. Indeed, this is a starting point that gives the opportunity to deploy other activities. This is the year 2019. The information about PrEP during LGBT conference, also a publication of the issues of PrEP on the website of the Public Health Center, also advertising about PrEP and participation in the March of Equality, where a Public Health Center took part in order to promote pre-exposure prophylaxis. Now the questions which are about information campaign and the history of clients, which is on the free access, and which also allows to have a look at the problem and its resolution. As the year 2021, it's a substantial information campaign, printed materials and the video of pre-exposure prophylaxis at the web page and support of the website for the communities, for the key populations about PrEP. Training of medical personnel, 2019, the first conference on pre-exposure prophylaxis. Public Health Center, with this example, demonstrates fighting against stigma and discrimination, which is also about pre-exposure prophylaxis. Also, it's about exchange of experience, how the experts of the World Health Organization are visiting Ukraine and share their experience that we are grateful to them for, as well as other international experts. And also, we are visited by colleagues from Belarus, Moldova, in order to have that experience. We are ready to share. The video course of pre-exposure prophylaxis was developed in the end of 2020, and nowadays we have over 1,200 reviews. And continuous education of medical personnel in the field of PrEP. Over that period, over 100 trainings and seminars and workshops was held, and this will be continued in the future. Also, as I work with communities, which is about training and promotion among the opinion leaders, as well as among the community leaders about pre-exposure prophylaxis, joint training, joint activities, online support of such activities. And generally, this conference, which takes place over the 3 days, it was actively developed and actively discussed also by the communities. And also it was intended for the communities of key populations. If we to speak about the government leadership and the issues on the level of the government, we have to mention the program of medical guarantees of 2021, which included pre-exposure prophylaxis. We understand this, and we also understand what to do with it, so that pre-exposure prophylaxis is not only for the donor money, that also there is responsibility of the government. And yet, as pre-exposure prophylaxis was included into the program of medical guarantees, and any person which is willing to obtain pre-exposure prophylaxis will call the service provider, and there cannot be a refusal of such a denial of such a service. Also, on the year 22, in our plans, its review of specifications, its improvement and inclusion into the program of medical guarantees of the indicators which are by the program of pre-exposure prophylaxis, and also about more global objectives that you may see on the previous slides. Those indicators which we have before us on the years 2021-2023, and we understand that moving force, driving force we expect from pre-exposure prophylaxis. We need to know what is the experience of other countries. As a previous speaker discussed Australia, we cannot reach that if we move way too slow. Therefore, as we understand what should be the coverage, what should be the outreach of the key populations, we remember of our aims and objectives, and we understand if there is full preparedness for implementation, we shall be able to implement. Summarizing this, I would like to mention the one key thing, that in the next steps, we will be providing medical drugs and social support for pre-exposure prophylaxis, having indicators on PrEP in the medical guarantee program, regular timely update of the regulatory framework, including the changes having place in the world, as well as decentralization of PrEP, including that on the primary level, on the grassroots level. I would like to thank the partners who participate, who actively help in implementation of pre-exposure prophylaxis, also especially of Public Health Center, which are actively involved. Thank you for attention. Larissa, thank you very much indeed for the presentation. From your presentation, we can see that over such a short time, we can see that a nice foundation was laid down for further implementation of PrEP. In addition, we have a nice team in the Public Health Center, as well as a team of our partners in the regions, 8 centers, and the websites, and we have communities of the key groups, key populations for further successful implementation. I can see we have a question. Yet I suggest we move it to the second part of the day, because we reached 3 o'clock. At 3 o'clock there is a break, and we have a...
Подякувати всім учасникам, і мені дуже приємно бачити, що кількість учасників
minutes in, so I'm very happy to see that the number of our participants has just grown. We have 373 participants in. I invite you to stay with us on the second part of this day. We will start in 15:20, and we will hear about the Moldova, Kherson, and Kharkov experience in PrEP implementation, and we will get the presentation from Atlanta from Roman University on the information how the behavior is changing, and also we got a presentation from a professor from Scotland, and I invite you to stay with us. Just mute your mic and see you at 15.
Сьогодні він з нею, завтра з ним, післязавтра з ними. Макс не обмежує свої бажання, але розуміє, що ніколи не може бути впевненим у випадкових партнерах. Тому Макс обирає доконтактну профілактику PrEP. PrEP – це таблетки, які не дають вірусу інфікувати організм. Їх приймають щоденно або ситуаційно до та після статевого контакту. Всесвітня організація охорони здоров'я рекомендує PrEP людям, які практикують незахищений секс, мають кілька сексуальних партнерів або партнера, який живе з ВІЛ. Завдяки PrEP Максим залишається здоровим та має свободу вибору. Він думає про себе, про нього та про неї. Подумай і ти. Обери безпечне життя зі свободою вибору. Захисти себе та інших. Зателефонуй на гарячу лінію з питань ВІЛ-СНІДу та завітай на сторінку Центру громадського здоров'я. Сьогодні він з нею, завтра з ним, післязавтра з ними. Макс не обмежує свої бажання, але розуміє, що ніколи не може бути впевненим у випадкових партнерах. Тому Макс обирає доконтактну профілактику PrEP. PrEP – це таблетки, які не дають вірусу інфікувати організм. Їх приймають щоденно або ситуаційно до та після статевого контакту. Всесвітня організація охорони здоров'я рекомендує PrEP людям, які практикують незахищений секс, мають кілька сексуальних партнерів або партнера, який живе з ВІЛ. Завдяки PrEP Максим залишається здоровим та має свободу вибору. Він думає про себе, про нього та про неї. Подумай і ти. Обери безпечне життя зі свободою вибору. Захисти себе та інших. Зателефонуй на гарячу лінію з питань ВІЛ-СНІДу та завітай на сторінку Центру громадського здоров'я.
Шановні колеги, таймер показує, що ми можемо...
Dear colleagues, we can proceed, and in principle, we stay within our timing, so the questions in the chat that we received in the first part of our conference will try to provide with the answers right now, and with every session we will see where we have free time for questions and we will answer them, and after finalizing all the presentations we will also address all the questions. And now I would like to present the next speaker, and I will switch to Russian because our next speaker is Yuri Klimashevsky from Moldova. Yuri is a coordinator of the National Program on HIV, AIDS and STIs prevention and control in Moldova, and we have a unique opportunity to listen to Moldova experience and to see how the public in state sector are cooperating and how we can work with the support of the government within the
Implementation of pre-exposure HIV prophylaxis in the Republic of Moldova is one of the components of HIV prophylaxis. About the HIV infection in Moldova, it is characterized as a concentrated epidemic within the following groups of risks: injected drug users, sex workers, and MSMs. By the survey of EBBS, the dates for 2009 till 2020, we see the decrease of HIV infected among injected drug users, commercial sex workers, but significant increase in the percentage among MSM. If in 2009 we got Kishinev 1.7, BLC 0.2, then in 2020 we have 11.6 in Kishinev and 8.5 in BLC. The estimated amount of the injected drug users, we have 27,500, sexual workers 15,800, and MSM 14,600. The normative basis for implementing PrEP: for the first time, PrEP as a specific goal ensuring universal access to PrEP was included in the national program of HIV/AIDS and STI for 2021-2025. It is good provided PrEP to both of the on the basis of medical institution and the basis of non-profit organization, updating the regulatory framework for the provision of PrEP in accordance with the latest WHO recommendation, campaigns to inform the population of risk groups and promote PrEP, roundtables on the results of introducing PrEP, identifying barriers in defining prospect. National Clinical Protocol number 313, pre-exposure prophylaxis of HIV infection, was approved by the order of Ministry of Health, Labor and Social Protection number 162 of February 7, 2018. It includes mandatory and advisory requirements. Mandatory requirements will be met without fail and are included in the institutional clinical protocols. Indication and contraindications for HIV PrEP According to NCP, indications: HIV negative status, significant risk of being infected with HIV, and a willingness to use PrEP in accordance with the recommended regulations, including periodic testing for HIV. Contraindications: signs or symptoms of an acute viral syndrome associated with HIV infection, including flu-like symptoms. Treatment: PrEP regimens. Our protocols prescribe continuous use of PrEP, that it means start at least 7 days before the risky situation, daily medication intake, stopping PrEP 28 days after the last high-risk situation. Observation in PrEP. Confirmation of HIV negative status every 3 months or first month after onset to exclude infection before PrEP, and then every 3 months. Testing for syphilis every 3 months. Elimination of side effects, identification during each visit. Brief adherence consultation during each visit. Estimation of creatinine clearance every 6 months. Once every 3 months in case of a history of kidney disease. And testing for HBV, HCV once a year. How we provide PrEP? First of all, it's provided on the basis of specialized medical institution. Counseling is provided by a physician and adherence consultant at the health center. Testing for HIV, syphilis, hepatitis, creatinine clearance is carried out directly in the laboratory of a medical institution. Second option, on the basis of non-profit organization, so-called community PrEP. Counseling of the benefits of PrEP, adherence, all necessary testing, including determination of creatinine clearance. It is carried by NGOs. Consulting on PrEP medical issues, interpretation of test results. Visiting medical officer of treatment centers does. And we have also mixed type when counseling on the benefits of taking PrEP and adherence issues is done by NGO employees. Then the client ready to receive PrEP is escorted to a specialized center for ARV treatment. Next, medical counseling is provided by a physician, and also testing for HIV, syphilis, creatinine clearance carried out directly in the laboratory of a medical institution. Shortly about statistics. On 2018, we got only one beneficiary. In 2019, already 90, and for 2020, we have 192. The types of PrEP on the basis of specialized medical institutions, 17, community PrEP, quantity of people 131, the mixed type 44. The quantity of who got the PrEP at least once during the reported period altogether: men 158, women 34, and there is among the risk groups MSM 137, sex workers 14, injected drug users 0, discordant couple 39, transgender 1, and can provide PrEP by demand. And if taking the percentage, the continuous PrEP is received by 42% and by demand 58%. Thank you very much for your attention. I'm ready to answer the questions, if any.
Здравствуйте всем.
Здравствуйте.
Good morning, everyone. First, very interesting to hear to your experience, and it is very important that you stressed the national records of legislative regulative documents that you implemented, and that you provide also on the community level and mixed type provision, and also on health facilities.
do you have approved the combined provision on the legislative level? And is it done by the order of MOH or some local regulations or some bylaw regulations? PrEP through NGOs as a method is all the same as it is done in health facilities. So the drugs are provided on the channel base because all the NGOs and non-profit organizations, they work all together with health facilities and ERT centers, and our doctors go to NGOs, to non-profit organizations. They also consult the clients over there. They provide consultations. In the first year, we've got just one beneficiary, as you see, as you have seen, for PrEP. And then we understood that we should go towards, we should go right in communities, to work with communities directly in order to increase the demand. And that was the idea from the very beginning. When you ask about the legislative base, so we just have a national clinical guideline. We updated it this year and in a new version, a new edition will include the access to PrEP through NGOs and non-profit organizations. In the reality, it is done, we only will fix it in the legislative base. That's all. To tell you shortly that PrEP in community, it's still the same PrEP. We just go directly to the beneficiaries. It's very interesting so how you worked with outreach, and you cover the costs from the governmental budget. Yes, it's already for the second year. We cover post-contact and pre-exposure prophylaxis, and also all other kinds of provisions within the HIV prevention. They are covered by the government. But I would say we don't buy Truvada, we buy generics. In generics, they're not so much expensive. It's just $5, one vial per month. And all the clients now switch to on-demand use. And then one vial is enough for even 2 months. And for the costs in this case, if we wait, the effect, so the cost of the effect is even less. Yes, so the state covers everything. Natalia, maybe you have questions? I see we have comments in the chat that Moldova experience is very interesting and very useful. Thank you, colleagues. And let me voice some questions from the chat. I will switch to chat, the Ukrainian language. First of all, we got the recommendations from WHO after the assessment of PrEP program in Ukraine. So those who want to see whether or not, which are the recommendations that we have in Ukraine, they can copy it from the chat, because we uploaded the information about the regulation hearing in the chat. And also we got the guideline from CDC. And this is really very important. So I invite everyone to use the CDC guideline and to use the principles in provisions in Ukraine. And also we got the comments of PrEP among the injected drug users, and I see in the chat that this topic is actively discussed in the chat, and the question was as such. So how we can start practically to implement PrEP among the injected drug users and to implement PrEP for this community. One of the recommendations that we got from the participants of our conference for the RTU, so it's very important to have the integrated websites where such patients could get PrEP, could get syringes, and also to get the opioid supplement therapy. And also there is a question of algorithm of activities. If a PrEP patient gets PrEP and he has STIs, so what should be the algorithm of our actions? Do we stop PrEP for such a client, or this client still proceeds with PrEP, but at the same time he seeks on the treatment against STIs? So I invite experts to think about this question and also the two questions from our participants. Our participants really liked the experience of Irina Zablotska from Australia, and namely, the question was about the relaxed criteria. So among those who have risky behavior, and how to implement PrEP and have the assistance from public and state sector. And the recommendation from Andriy Chernyshov concerning the experience from communities, so to involve clients from communities and diversify the services in the centers, where the client can get not only PrEP but also to get the diagnostics for STIs. So Larissa, please, also I present you the review of the issues that were stipulated in chat. Okay, you know, for STI we will have the separate discussion. For example, tomorrow we will have this topic in discussion in the panel, and the speakers, if the speakers are ready also to comment on the question now, so I invite them to chat if they have the opportunity. So I invite them to discussion, please. Then we leave this question for tomorrow's session about STIs. Natalie? Okay, I got the response from Yanis concerning in case the client has the STIs. So I will voice it. Yanis says that we never stop PrEP when we start STIs, and accordingly to the WHO guidelines, such recommendation is in this guideline, and Yanis is ready to provide the detailed response in order to tell about how we can combine STI treatment with the clients who stay on PrEP.
Ian, I think, will speak about it tomorrow. Thank you, Natalie. And we move forward.
I would like to introduce the next speaker, Dr. Tom Smith, the Department for Health of the United States, the specialist for the regulatory framework and implementation and monitoring of pre-exposure prophylaxis of the Department of HIV/AIDS Prevention. I would like to say that the program of PrEP of the United States, New York, is a story of success. Therefore, it will be interesting for us to know and understand how those programs were implemented in the United States. So we give the floor to the next speaker.
Hello. I want to thank you very much for inviting CDC to participate in your conference. I'm going to talk about scaling up PrEP provision in the United States and where we stand in 2021. So in the United States, in 2018, the last year for which we had this, this kind of data, there were about 38,000 new HIV infections diagnosed. And of those, 2/3 were in men who have sex with men. Another almost quarter, 23%, were in persons who reported heterosexual contact, 16% female and 7% male. And another 10% were in persons who inject drugs, including 3% who were female, 4% who were male, and 3% who reported male-to-male sexual conduct in addition to injection drug use. We also have a small contribution to the epidemic of transgender men and women. They accounted for 1.5% or less of the new HIV diagnoses in 2018. In response to our epidemic and the kind of slow but decline in new infections, the federal government has launched what they call the Initiative to End the HIV Epidemic in the United States. And it's composed of three main components. One is to test more broadly for HIV infection so that those who are determined to have HIV can be provided treatment, which when it lowers their viral load with antiretrovirals, both benefits their own health and reduces their likelihood of transmitting HIV to others. Those who test negative can then be evaluated for what's the best prevention method for their benefit to keep them from becoming HIV infected. And PrEP is a main component of this prevent component. What you'll see is that in 2017, the base year of this initiative, only 63% of those who were positive were virally suppressed, and only 18% of those who were negative but who had indications for PrEP were taking it. So first, I want to explain some of the implementation challenges that we faced in the US. These may be the same or different than what you face in the Ukraine. First of all, PrEP was considered controversial when it was introduced. And over the 10 years that we've been trying to implement it, there have been many changes in the PrEP field, and responding to change and uncertainty are very difficult in the policy environment in the United States. In addition, we simultaneous to introducing PrEP need to scale up HIV testing, linkage to HIV care, and treatment services for persons with HIV. And last, the groups who have the highest HIV incidence in the United States have been shown to have low awareness of PrEP and less access to affordable health care. The US healthcare system is a very fragmented system, and I'm going to go through a little bit of it so you'll understand some of the barriers that we had in the US to scaling up PrEP. We basically have a fee-for-service system, which means somebody has to pay for any healthcare service that you have. but the different ways of paying for it are distributed in several ways. So first of all, some programs have limits to eligibility for coverage. Insurance programs, for example, may, some of the public insurance programs rely on income. Some are specific to special populations. So for example, we have a program that provides HIV treatment that's separately funded from the rest of the health system. The services that are available can differ based on whether it's walk-in care, hospital care, or specific health conditions. And the services that are covered by the various payers often have limits on the amount you can spend in a given year, or the amount you have to spend out of pocket before they begin to pay. They also have some limits about preventive care and medications. The source of payment for these variety of health services differs. So about half of the funding for healthcare insurance in the United States comes from your employer. Most employers offer subsidized health insurance for their employees. About another almost 10% purchase private health insurance on their own. These are often people who don't work for large employers, maybe they're self-employed, etc. The rest of the market, about 7% are uninsured, people who have absolutely no source of health insurance. And then we have publicly funded programs for the elderly and the disabled, for those who are very poor, and for those who are in the military. Each of these programs has its own rules about how PrEP would be covered. In addition, because PrEP is a clinically delivered intervention, it requires that we had to identify and train new providers. We did this by issuing guidelines and setting up programs for provider education. It also requires coordinating the clinical, behavioral, and social service interventions that providers need with the clinical care providers. And we've done that largely by instituting systems of what we call navigation. Sometimes these are peers, sometimes these are professional health staff. In addition, we needed to provide financial assistance for those persons who are uninsured or who have limits on their insurance for the medication, the clinical, the laboratory, and the counseling costs. And we've done that by working on setting up PrEP medication assistance programs. The drug company has one, the federal government has one, and several states in the United States have set up their own medication assistance programs. In addition, we were very actively engaged in policy interventions to ensure that, for example, health insurers were able to provide PrEP with no out-of-pocket cost to patients by getting a policy statement from one of our healthcare policy boards. You can see here that over the years that we've been working on this, the number of providers who are aware of PrEP has consistently gone up and is now almost 90%. On the other hand, the number who have prescribed PrEP, while it has increased, is still running at about 15%. So we have a lot to do to convince providers that this is the service they need to provide to their patients. While we were doing this, this is the increase year over year in the number of persons who were prescribed PrEP during a given year. You can see that in 2019, we were up around 275,000 persons who were prescribed PrEP in that 1 year. The red bullets are where we issued guidelines for PrEP. So, as I said, things have been changing rapidly in this field. And while we issued the initial guidance for MSM in 2011, for heterosexuals and persons who inject drugs in 2012, our first comprehensive guidelines were issued in 2014, were updated in 2017, and are now in the process of being updated this year. As a result of these changes with providers, If on the left, you can see where the number of persons diagnosed with HIV in 2019 lived. Darker colors is higher numbers of persons. And compare that to the percent of persons who have indications for PrEP who were prescribed it. And what you can see is that there are many places where there are lots of new infections and much less PrEP provision, particularly in the southeast portion of the United States. In addition to geographic disparities, we have disparities by race, ethnicity, and sex. So in gold, you'll see on the left people who have coverage who were provided PrEP. And on the right, you'll see the number of people, the percent of people who had indications for PrEP. So although of all persons with indications, white people constituted 29% of those with indications, they were 63% of those who actually received a prescription. And among African Americans, for example, while 40% had indications, 8% received PrEP in 2019. Then when you look at men versus women, you see that indications for PrEP were highest for men at about 81%. But coverage of those who had indications, what proportion were prescribed PrEP, was only 26%. And women had lower indications, but they also had lower levels of PrEP prescription. So as a result of these changes that we've made and the successes we've had so far in getting PrEP prescriptions up in the United States, we have some early evidence that it's making a difference in HIV incidence. So in this analysis, where we looked at changes over several years in the rate of change of PrEP prescription and compared it to HIV incidence, controlling for changes in viral load suppression, what you can see is that in the leftmost quartiles, which were the lowest rates of increased PrEP use, you can see that there was essentially no change in HIV incidence. However, in the right two, where you had the highest rates of PrEP uptake, you also had the highest declines in HIV incidence. Similarly, in New York State, where they looked at increasing rates of pre-exposure prophylaxis, and they also saw decreasing rates of HIV diagnoses over the same time period. When you look within a specific clinic, for example, there was a clinic where they followed cohorts of MSM over a period of time, and what they found was that during the period of time when men were not taking PrEP, they had an HIV incidence that was a little above 1. When they were on PrEP, it was pretty close to 0. And when they later went off PrEP, it went right back up to above 1. Was an early warning sign of an issue that we're having to deal with now, which is getting participants on PrEP to actually stay on PrEP throughout their period of risk. So what are our next steps? First, we want to increase the number and type of clinics that are providing PrEP. That includes in-person care through community health centers, STD clinics, family planning clinics, opioid substitution therapy clinics, and harm reduction sites, but also virtual visits. COVID-19 has taught us a lot about how to do this. Telehealth visits by phone or by online video, mail-in laboratory testing, mail-order medication, etc. We also need to increase the awareness of PrEP in a diverse user population. Part of this is demand creation, making people aware and of how PrEP can benefit them so that they're in a position to ask their providers to prescribe it for them. The other part is to reduce misinformation about PrEP and PrEP stigma in the community that surrounds potential PrEP users, so that when they do initiate PrEP, they're supported by family and friends. The third thing is prepare for the introduction of new, longer-acting PrEP modalities. The work we've done so far has been with daily oral pre-exposure prophylaxis using tenofovir-based regimens. but injectable cabotegravir has shown to be highly effective, and we anticipate that very soon we will have FDA approval for using that as well. Those are injections every 2 months. And last, the dapivirine vaginal ring, which is slowly releases dapivirine and has to be replaced monthly. We are also anticipating an FDA decision about dapivirine. So thank you very much. I hope you understand a little bit more about what we've done in the United States, and I look forward to your questions.
Модан, за таку презентацію. Нам приємно було ознайомитися з досвідом. І я звернула увагу, що бар'єри, які ви зазначали...
Thank you for this information. I'm grateful for your experience. The barriers you have mentioned are similar to our barriers. Such barriers as payment for the services nowadays with donors. The services for PrEP clients are provided free of charge. It was interesting here to hear the experience of the United States, where PrEP services are paid by the employers. That's interesting experience. At the same, it's important for us to have the integration, as you have mentioned, which is about when the client has clinical needs, there is behavioral needs, there is the need for social services. So integration of those three services for us is as important. And the model that you have proposed, the model of navigation of the patient in order to receive all these services is also very important. The percentage that you have quoted in your presentation about the involvement of family doctors, 15%. I believe that my colleagues will support. For Ukraine, there is a challenge of diversification of sites of PrEP provision and also involvement of family doctors or GPs. And the positive results you have demonstrated on a reduction of incidence is impressive. 65,000 patients on PrEP caused the reduction of 55% of new cases of HIV. That's impressive result. Thank you.
Thank you.
I would also thank Dawn for your experience. Yes, really, lots of issues that we can borrow as experience and to implement in Ukraine. And also, we have lots of appreciations for the presentation, for the experience that was presented for you, Dawn, and also from the previous presentations. We have the comments to the previous presenters as to the opportunity to dispense PrEP not by one provider, but also to involve family doctors and other healthcare professionals to dispense PrEP.
Like many other places, when PrEP was first introduced in the US, it was largely available through infectious disease clinics and HIV experienced providers, treatment providers. But because people who don't have HIV don't go to infectious disease clinics very often, and because many people in our communities don't want to be considered to have HIV when they don't have it, we are really working hard to engage the primary care providers, family health providers, general internal medicine, women's health providers, other kinds of primary care providers to offer PrEP to their HIV negative patients that they're already seeing who may have an indication for PrEP. This both is a workforce issue in terms that we have, a finite number of infectious disease doctors, and they need to focus on the treatment of HIV infected individuals, and an issue of destigmatizing PrEP and making it a primary healthcare practice, not an HIV practice.
Лариса Іванівна, якщо ви дозволите, я бачу в чаті тут питання до Dawn, і питання стосується
and namely the issue is about prescribing PrEP. I mean, as to the administration of PrEP, did you have any regulatory or legislative amendments incorporated in the normative database in order to roll out the PrEP prescription?
Can you say again, did we have regulatory issues related to what?
What was regulatory changes required as well as practical recommendation for implementation for PrEP among people who inject drugs? Do you have any specific recommendation to Ukrainian colleagues that we can take into consideration for our practical implementation? Because at this stage, we don't have any practical experience, very anecdotal experience for PrEP implementation in Ukraine. Thank you.
I think that PrEP provision to PWID has lagged very much in the United States. And it's not primarily a regulatory issue. We have FDA approval for PrEP use. Our guidelines call for PrEP use in PWID since 2012. However, initially there was a lot of reluctance on the part of programs that provide care for PWID. There was a lot of reluctance to provide PrEP. For two reasons. Number one is they felt that they were reducing their risk through their activities, through syringe exchange or through opioid substitution therapy, and therefore their patients didn't need PrEP. But over time, they came to accept that that PrEP that PrEP, in addition to those activities, is an extra layer of protection that benefits PWID. And so as they came to understand that these were not competing methods, that they were cooperative methods, there are more and more centers that provide care for PWID who are trying to incorporate PrEP. The additional problem that we're having, though, is that many of our programs are not clinically based. They are either counseling-based programs or they are needle and syringe exchange programs where they don't necessarily have the ability to check for creatinines or do STI testing. And so we're having to develop more collaborative, navigated models so that we can provide PrEP to PWID in the places where they're seeking other kinds of care.
Thank you. Thank you for your guidance, Dawn. Thank you.
Are there any other questions?
У нас, я думаю, якби у нас було більше часу, питань було дуже багато. У нас є
we would like to have more time to question, but so far we have the comment from Yanis. We switch to this session now.
Я хотіла попросити технічних спеціалістів відкрити мікрофон для Яніса. Будь ласка.
Please connect Yanis. Technical support personnel. Please connect Yanis.
I'm okay with technical support. I just wanted to thank Dawn Smith for her wonderful overview, the experience in the US. Thank her for her leadership actually in PrEP guidance and, really kind of really helping shape programming in the US. And we really, I think, appreciate her comments just now on the challenge in moving, sort of thinking about PrEP in this in serving people who inject drugs. This is definitely a population for which we need to do more brainstorming and put things on paper and think about having some some of these sort of collaborative models that you mentioned on. And I think on a sort of very pragmatic note, probably a follow-up with U.S. partners, yourself, and maybe some of these other sites that you've mentioned that are trying to make this happen, I think would be very constructive. And also Ukraine looking at this PrEP, in the context of harm reduction services, is something that really can be useful for other Eastern European countries and other countries in other regions. I think it's, you've recommended this, as you said, since 2012. It's in the guidance, PrEP for people who inject. WHO's guidance is also permissive to PrEP being offered to people who inject, but it's in terms of documenting this and showcasing this and having maybe sort of more meaningful coverage is in my mind, I don't see it right now. So I think there's a lot of work there ahead of us. And again, thank you to Dawn for her wonderful presentation.
Giannis, we'd be very happy to work with you to put together a further conversation about this issue. I didn't mention in the original slide, but when we talk about the initiative to end HIV in the US, in the prevention component, there are two primary activities. One is PrEP and the other is expansion of syringe service programs. So we are working very hard on both fronts in terms of prevention, and clearly integrating them will be important.
Дякую всім за цю сесію, за прекрасну дискусію. І я хочу представити наступного спікера.
Thank you very much for the session. Thank you very much for the participation in this panel. And now I would like to present Natalia Ryzhenko, Head of Trust Cabinet, Private Counseling Room in Kherson. She is the first doctor who started to implement the PrEP programs in Ukraine. She was and is very active, and she really was the one who stayed at the beginning of the PrEP. Good morning, dear participants of the conference. I would like to tell you about our experience in implementing pre-exposure prophylaxis on the site where I worked. This is a municipal non-profit enterprise. Good morning, dear participants of the conference. I would like to tell you about our experience in implementing pre-exposure prophylaxis on the site where I worked. This is a municipal non-profit enterprise, Kherson Regional Clinical Hospital, named after Karabalysh. We decided to implement this additional service as a pre-exposure prophylaxis due to the worsening of the situation in our oblast, because we have 5,553 persons with HIV, plus estimated amount of population at risk for HIV infection. This is 10,000 people, out of them 6,000 injected drug users, 2,600 sex workers for remuneration, and 1,400 of MSM, out of them 74% of injected drug users, 64% of sex workers, and 54% of MSM live in Kherson city. That's why PrEP, to our opinion, is a high potential prevention tool. Since October 2020, program on improving quality of service of index HIV testing and scale up the PrEP coverage, and through the support of International Center of Healthcare Education and Training from Washington State University. within the framework of President Emergency Plan for AIDS Relief, and the aim of the program on improving quality of service of index HIV testing is in order to increase the identification of new HIV cases and scaling up ART and PrEP services to negative partners of people living with HIV, to reduce the risk of HIV transmission. And one of the objectives of our program is involving sex and injected partners of HIV positive patients of our site, of those who got HIV negative test within the index testing program, and other clients of our site who got follow into high risk population to PrEP program. Our professionals approved and implemented the programs of daily prophylactics and on demand, like 2+1+1. Together with ITEC, we trained our specialists, and the issues were dealing with clinical and laboratory monitoring of our patients, of dispensation of PrEP to our clients, and we have patients, 6 patients altogether, who proceed with PrEP. Out of them, 3 already have the experience of PrEP within other facilities of Kherson City. Out of them, 5 are sex partners of HIV discordant couples, and 1 of them is MSM. Those patients took decision for daily PrEP, and they tolerate quite well. We've identified no cases of transmission from them. We test them in the same laboratory where they receive PrEP, and they have the opportunity to use services of consulting from a dermatovenerologist, the support from social workers to get the information in literature, and also to get the barrier contraception. That's why, as our experience shows, implementation of different programs altogether, the synergy of programs of PrEP and index testing involving the patients with a high risk of HIV infection gives us very good outcomes, and I think that the administration of PrEP will provide us with the opportunity to decrease new cases of HIV infection.
Natalia, thank you very much for your experience. Thank you for your presentation. We have questions. The sites where, health facilities where you deliver PrEP test is really great, but what is your view on decentralization? With the experience that we got since our medical community, as medical community, we don't have the let's say the access to the key population communities. That's why here we have to work all together with so-called in public-private partnership in using the non-governmental organizations in order to get access to the key populations in communities would be very effective. This is concerning small cities and towns on the local level, because NGOs, not all, they don't, let's say, cover all the services with key population. Same, the healthcare professionals can help in this area,
And we worked in tight contact with NGOs. We used mobile vehicles for testing the key population. We also did altogether the consulting activities. I was invited to community centers where in the friendly atmosphere we discussed all the issues of PrEP and other issues. And now I involve even the patients themselves. For example, if we don't have contact with some NGOs, so we involve the clients, in this work, or those who, those persons who stay at high risk. So we involve them for promoting PrEP among their relatives, among their friends, using social networks, and it really works. It gives us good effect, and we've got patients who brought their relatives, their friends to our cabinet, and so we got new users through this practice. And also, what about the monopolization of dispensing PrEP? Yes, when we talk to clients, they express that they would, but just welcome to get PrEP through the health facilities, but also other sites. And also, they ask to develop so-called a specific map where all the centers of PrEP dispensation would be marked. Thank you, Natalie, for your experience. And so far, there are no questions. And Larissa, we will move forward. Thank you, Natalie, for your experience. I don't see any questions to Natalie. Okay, I would like to present you another speaker. This is Anastasia Kuznetsova, the head of clinical outpatient department of the Regional Clinical Center for AIDS Prevention and Control from Kharkiv. Anastasia has great experience in counseling, in training, in working directly with patients, and it's a great experience. Anastasia, you're welcome. Good morning, dear colleagues. I would like to present on duration and maintenance of persons who took pre-exposure prophylactics, tenofovir and pirtobrutinib in Kharkov region. The epidemic of HIV infection stays high in most of the countries of the world, notwithstanding the vast coverage. The HIV infection stays untreated and has negative impact on health. That's why we decided to study duration and maintenance of the persons who took tenofovir and pirtobrutinib as PrEP during 2020. We took the study made on the basis of the communal profit experience of the Kharkov Oblast Council from Oblast Clinic Center for HIV Treatment Prophylactics during 2020. Under the observation, we got 166 persons who took tenofovir and pirtobrutinib as PrEP during 2020. Out of them, we get 4 women and 162 men, mean age 25 to 27. We distributed those persons 160 MSM and 6 persons who got contacts with HIV positive, out of them 4 women and 2 men. For the duration of PrEP, we found that among MSM, the PrEP was taken during 3 months, 20 persons, that made 12.4%, during 9 months, 29 persons, 17.4%, 13 months, 22, persons, 13.2%, and next month 18, next 4 months 13 persons, 9 months 18, and 2 accordingly 2 and 11 months. Out of those who had contact with HIV positives, 3 persons took during 1 month and 2 persons during 2 months, and they stopped voluntarily the intake. Under the detailed study in dynamics and at the beginning of PrEP, not a single person has the antibodies to HIV, neither the high creatine clearance and the glomerular filtration rate, but among MSM who took a PrEP during 1 month, we found hepatitis B in 2 persons, and syphilis in 4 persons. In the beginning of 2021, 26 started to take PrEP. Again, who took PrEP for 9 months, and 22 who proceeded to take it from the very beginning. So basing on the results of the study, we can say that the highest quantity of persons who took tenofovir emtricitabine as PrEP during 3, 9, and 12 months, or during the prolonged intake of PrEP, none of the persons showed the antibodies to HIV, increase of creatinine clearance and glomerular infiltration rate. We managed to get back to PrEP 48 persons from group of MSM, and we have to mention that in our study, we have the result such as that tenofovir and emtricitabine are completely effective and risk-free. That will help us to reduce the new numbers of HIV infection. Thank you for your attention. Unfortunately, we didn't get Anastasia connected, so we express gratitude to her for her experience. I don't see any question to Anastasia, and we have just a comment that the PrEP intervention should be developed using the experience of neighbor countries, I mean from the countries from the region. My question to Anastasia, so I would like to know what was the experience in PrEP administration to patients, namely how they worked during COVID-19 pandemic. Did they modify their services during pandemic, and the PrEP was dispensed on regular basis during pandemic times? Okay, let's move forward. Now we got Roman Ivasev from Georgia, Atlanta. He's a doctor of medicine, master of public health, postgraduate student, and his topic is bullying towards LGBT plus students and high-risk sexual behavior in Ukraine. Roman is from Ukraine. He's a doctor who participated actively in anti-HIV programs in Ukraine and Friendly Doctor program. Roman did dozens of trainings on the topic of stigma and discrimination, and we welcome Roman here because he will be involved in the study on HIV and STIs in Yale.
Hello, everyone. I'm very honored to present at this conference today to you. Let me introduce you to my study, which is bullying experience of LGBTQ plus students and sexual risk behavior in Ukraine, which is a cross-sectional study. And it was part of my thesis research for my MPH at Georgia State University. Here is the brief content of my today's presentation. I will start with the background, then proceed to the materials and methods, then discuss my results, and finalize my presentation with a discussion and conclusion of this research. So we have reasons to believe that school bullying can be associated with sexual risk behavior in Ukraine, specifically in the LGBTQ plus young population, because bullied LGBTQ plus adolescents in the United States were 1.93 times at risk of engaging in casual sexual contact. Also, anti-gay verbal and physical peer-driven harassment has an effect on increased sexual risk through the mediation by depression, substance abuse, and sexual partner violence in the United States. Regarding Europe, there are data from Greece that suggests that students bullied at high school less likely to use condoms during the college attendance. And regarding Ukraine, we have WHO research that reported that there is no association between bullying and early age sexual onset and having multiple sexual partners. However, this study also reported that peer-driven violence without specification of the setting, it could be school or other setting. So this kind of exposure was associated with both given types of sexual risk behavior. So the research question is there any relationships between sexual orientation and gender expression-based bullying exposures and sexual risk-taking behavior among LGBTQ plus students in Ukraine, and whether there is any mediation roles of depression and low self-esteem on this association? You can see on this graph the conceptual model of this research. Regarding materials and methods, so for this research, I used data from the 2020 Ukrainian School Climate Survey conducted by Parental Initiative Tergo and funded by the Royal Norwegian Embassy. The methodology of the survey was developed by Gay Lesbian Straight Education Network, which is the United States-based NGO, which has been working on this type of research since late 90s. And secondary data use approval was obtained from Georgia State University Institutional Review Board. Materials and methods, like following the discussion of it. So this survey is 100% online survey. We used 132 item questionnaire placed on Qualtrics and distributed through social media such as Facebook, Instagram, and TikTok using targeting algorithms, focusing on students who attended school in 2019-2020 academic year and those who identified themselves as LGBTQ plus students. We collected data from April 2020 through August 2020. Exposure variables were established through the self-reported answers to the question you can see on this slide, and we use the Likert scale to measure them. So dependent outcome variable, which is sexual risk behavior, and it was described more in detail in the beginning of this presentation. So we used this set of questions to identify those who had been engaged in one of the sexual practices that are considered as high risk in terms of HIV transmission based on the literature. So the results, here you can see that we have almost every region represented in the study except Crimea, because we could not reach this population, probably because social media targeting algorithms do not consider Crimea as Ukraine, unfortunately. For instance, in 2017, we were able to get responses from this area, but this year, we have no one from Crimea who identified themselves as LGBTQ plus and were at school during the last academic year. So the final sample was 1,743 people. Half of them were from urban areas and 1/4 from suburban and around 30% from rural communities. Regarding age, you can see that the mean age of study sample was 15.3 years old. In terms of gender, we can see that the most prevalent subgroup is cisgender female, which is 73.9%, and cisgender male were represented only by 14% of people. This is a common pattern to see this kind of gender distribution within the study samples of school climate surveys in Eastern Europe, in the United States, and other European countries, as well as Latin American countries. Because young gay and bisexual men, they are considered as a hard-reach population, and there are a bunch of techniques to increase their participation, but using some of them we only able to get only 14% of this population into this study. In terms of sexual orientation, the most prevalent subgroup is those who identify themselves as bisexual and pansexual. It's more than 65%. Gay and lesbians, 25.3%. Those who were questioning their sexual orientation is 7.4%, and those who identify themselves as queer, just 1%. Here on this graph, you can see the prevalence of different bullying exposures, such as verbal harassment based on sexual orientation was reported by more than 50% of students. The most prevalent was verbal harassment based on gender expression, reported by almost 60%. Here within the column, you can see that different colors indicate the frequency of this exposure, whether it was frequently, often, sometimes, or rarely. The least prevalent were physical assaults based on sexual orientation and gender expression, and sexual harassment and cyberbullying were both quite prevalent compared to other exposures here on this slide. Here is the main findings of this study, and we can see that those who were exposed sometimes, often, and frequently to verbal harassment based on gender expression, physical harassment because of gender expression, sexual harassment and cyberbullying had higher odds and statistically significant higher odds of being engaged in high-risk sexual risk behavior, which was defined earlier in this presentation. After the dichotomization of the exposure variables, so basically I transferred those who reported sometimes exposures to an unexposed group. So we can see that the more frequent exposure to physical harassment and gender expression and sexual harassment, the stronger associations are with sexual risk behavior. For instance, it increased for physical harassment based on gender expression 1.9 odds to 2.7 odds. Analogous pattern of increase you can see for sexual harassment as well. Here are the more, on this table, you can see the more detailed results with the 95% confidence intervals. So the conclusions. So verbal and physical harassment based on gender expression, as well as sexual and electronic harassment, are both associated with sexual risk-taking behavior among LGBTQ+ students in Ukraine. The more frequent exposure to physical harassment based on gender expression and sexual harassment, the higher odds of sexual risk behavior. Gender expression is the particular reason for bullying that correlates with sexual risk-taking lifestyle. The mediating roles of depression and low self-esteem on the relationships of bullying and sexual risk were not statistically significant, and the evidence which we gained from this study underlines the necessity of inclusive anti-bullying policies that could decrease exposure of LGBTQ+ students to bullying based on prejudice and gender expression. We also have reasons to believe that inclusive bullying prevention could contribute to minimization of HIV incidence among adolescents in Ukraine through sexual risk decline. Thank you again, and looking forward for the discussion afterwards.
Дякуємо, Романе, за такий ґрунтовний...
Thank you very much, Roman, for such a grounded study and very interesting presentation, but I don't see any questions to Roman. There's only a comment that we have to think about other reasons like self-isolation, like anxiousness, because of COVID. And maybe you can comment the situation as well.
So I should answer in English. They asked me, thank you again for having me. I really appreciate the opportunity to present for you today. And so the probably the most valuable part of this study is to show that queer adolescents who are attending secondary level schools in Ukraine, they are all at risk of being engaged in unprotected sexual risk behavior, regardless of their gender. And there was quite of insight for me as well, because even if I looked at the actual data, so even a cisgender female who identify themselves as bisexual or gay or lesbian, they also had a tendency to being engaged into unprotected sexual misbehavior, which is also quite a phenomenon that we need to understand more. And in terms of PrEP implications, so the target audience for PrEP is young MSM and gay bisexual men, and not only young, but all of them. And you can select hard reach relations. So we, I'm sorry. So we, excuse me. So we need to find a better ways to reach them, because social media targeting is very poorly works for MSM. So for instance, young bisexual and lesbian women, they are more likely to participate into social study and into social movements like civil rights movement. Otherwise, gay and young bisexual men, we need to use probably more entertainment targeting techniques to reach to them. And this could be one of the implications for PrEP implementation as the distribution strategy, because we need to think more how to reach, because all around the world they are considered a hard reach population, and focusing on more entertainment interests rather than social movement interests of their is better approach to reach them. And I think that it would work for PrEP implementation as well, like if we want to reach the audience using social media targeting.
Дякую, Романе. Дуже цікава дискусія. На жаль, у нас немає часу, щоб її продовжувати.
Thank you. This was quite an interesting discussion. I will allow myself another question. Whether bullying has increased during COVID? Speaking of Ukraine's experience, I don't know of such numbers or studies to confirm that. Most probably yes. Or maybe there is an experience in your country.
So in the United States, so they're about to publish their they are just starting their new school climate survey in the United States, and they are changing the methodology completely considering the COVID in pandemic. So this data probably will be available like in a year and a half in the United States. In our case, so we were collecting data a few weeks after schools went to a lockdown, and like students were not presently at school. So it might result in recall errors, so which is one of the limitations of the study. But in general, comparing the data from 2017 to 2020, we see like lower prevalence of bullying among LGBTQ plus population in Ukraine. But it has nothing to do with COVID. But as I said, COVID might affect also that students were not at school, and they probably do not remember all of the things that had happened to them before. So it's one of the limitations.
Дякую, Романе. Дякую, що ви таку знайшли можливість приєднатися до нас і представити.
Thank you for joining us. Thank you for presenting this study. I would like to introduce the next speaker, Claudia Skur, professor of the Department of Social Health in Scotland. The history of success in extension of pre-exposure prophylaxis in Scotland. This is the name of this presentation, pilot project of PrEP for injection drug users in Scotland. Of course, the history of Scotland is true success. And we invite Claudia to share that experience.
Good afternoon, everyone. We have about 5,600 people living with HIV in Scotland, and about 200 people newly diagnosed with HIV each year. Half of these are gay and bisexual men who have sex with men, and about 25% have acquired HIV recently. We're exceeding our 90-90-90 targets for clinical care. We've had a national PrEP program for almost 4 years since the middle of 2017, and 4,500 people have been prescribed PrEP at least once. Almost all have been gay and bisexual men who have sex with men. Just over half take PrEP in a non-daily regimen, and 4 people are known to have seroconverted, and these are people who've had PrEP at least prescribed once. The PrEP program is delivered through free sexual health clinics as part of combination HIV prevention within wider sexual and reproductive health care. And we've had a national monitoring system implemented since the beginning of the PrEP program. What we decided to do was to try and determine the population level impact of PrEP on gay and bisexual men who have sex with men. You'll see here that we conducted a retrospective case control analysis where we looked at men in 2 years before the PrEP program and compared them with men in the 2 years after PrEP was introduced. What we found was that new HIV diagnoses declined by 20%, and recently acquired infections were down by about a third. Interestingly, the incidence of HIV in men prescribed PrEP declined by 75%, but incidence also fell in MSM who had not been prescribed PrEP, but to a lesser extent. We also found that men who had had a previous STI or previous PrEP were those at highest risk of HIV, and it was encouraging to see that uptake of PrEP was greatest in these groups. In a parallel study, we wanted to look at the characteristics of people who were newly diagnosed with HIV since PrEP had been introduced, and we compared those people in the first year of the PrEP program with people newly diagnosed with HIV in the 2 years before PrEP was introduced. We also wanted to determine what proportion of those new diagnoses hypothetically could have been prevented using the PrEP model where PrEP was delivered through sexual health clinics. We found that there were quite big differences in the people diagnosed with HIV pre and post PrEP implementation. In the time of PrEP, those diagnosed were less likely to be male, less likely to report transmission as sex between men, and less likely to have acquired HIV in Scotland. A very small proportion of diagnoses were potentially preventable with the existing PrEP model where people had to attend sexual health clinics. This really showed us that we needed to be thinking about additional models of PrEP provision within broader combination prevention strategies in a range of settings, not solely sexual health clinics. So we asked ourselves, whose PrEP needs are not being met, and what does the evidence tell us as to how we should address this? In the interests of time, I can't present the work we did in women of colour in Scotland and London, nor work done by community groups with trans and transgender people. However, I'm going to spend a little bit of time talking about the perspectives of PrEP in people who inject drugs. Glasgow is the largest city in Scotland, and we have an ongoing outbreak in people who inject drugs since 2016. The group we surveyed really thought that PrEP could be beneficial, but they had very low awareness of PrEP. In terms of what they wanted, is they wanted PrEP to be available to them, but in models of care with which they felt familiar and in settings with which they developed trust with healthcare and social care providers. And that promotion of PrEP should include people from their peer group. Since then, we have a demonstration project where we are providing PrEP for people who inject drugs in Glasgow. We have about 45 people successfully taking daily PrEP, and their risk is largely sexual. However, although feasible, the resource required to run the program and support people comprehensively is very high. So in terms of our successes and challenges, we've done well with the people who are relatively straightforward, the easy wins, but we need to be looking as to how we can provide them with PrEP in a way that is streamlined and hopefully cost effective. We can provide PrEP to people who inject drugs, but it's very resource intensive. And we need to be thinking beyond sexual health clinics in how to deliver care to a greater variety of people. This is where we are thinking about an e-PrEP clinic in which a person is initiated on PrEP face-to-face, but the 3 follow-up visits over the course of a year are done through an online automated consultation with postal self-sampling for STIs and HIV. This will be integrated with the electronic patient record, which is used across all the sexual health services in Scotland. What we hope is that it will allow people to access PrEP easily and conveniently and give us space in clinic for people with more complex needs. And we do think that it is the tool that we will need to scale up PrEP provision across the population for elimination of HIV transmission by creating more capacity in the sexual health clinics and by reducing the overall clinic burden and increasing access to the geographically remote. So we've shown that combination prevention is key, but it needs to be tailored. We need to work hard with non-gay and bisexual men who have sex with men. We've made a good start, but it's now getting harder. And of course, our rigorous evaluation must continue. Thank you very much for your time.
Клаудія, дякуємо за вашу презентацію.
Thank you for this presentation. Thank you for the experience you have presented. Regretfully, the success on the reduction of new cases as a result of prevention. And we again can see the need for wider use of pre-exposure prophylaxis, not only inside the clinics, also expanding that also to include other sites. As you have quoted, there are sexual health clinics, and you believe you must include more sites. Also, we can see the thanks in the chat for the results and for achievement of adherence to pre-exposure prophylaxis among injection drug users. We have several questions to Claudia. I will start with the first question. The question was as follows. So Claudia has mentioned that injection drug users who are on the PrEP, mainly they had sexual risks. Does it mean that they did not have had no risk related to injection drug use? Was this understanding correct, or maybe they were on the prevention program or the needle exchange program as well? Thank you, Claudia.
Thank you very much for that question. It's a very good question. And you've highlighted an area which shows how we worked quite creatively to get round regulations. So currently we provide PrEP to people who have a sexual risk. They are not the most chaotic in our population, and they do not tend to be the people who are currently sharing needles. We've had to prioritize people we think in whom it is feasible that we can see them on a daily basis, give them their replacement therapy, and they get their PrEP at the same time in the community pharmacy. One of the reasons behind that was that PrEP in the UK is not licensed purely for an injecting drug risk, so we were only able to work within that framework. So it was a little bit of creativity to try and see how we could extend the benefit of PrEP into a population where there was a lot of sex happening, a lot of exchange of sex for money, but using it for the people we thought we could realistically maintain on PrEP because they were not the most chaotic, they were not the ones who were currently injecting.
Дякую, Клавдія. Я бачу руку Лариси Іванівна у Мартіна Донахью піднята.
Thank you for this, and the hand is raised by Martin Donahue.
Martin, please go
yes,
ahead.
Can you hear me? I'm not sure whether I've got the Claudia. That was really fascinating. Even though I'm now working in Ukraine, but back in the last century, I was working in United Kingdom, and it breaks my heart in some ways that we had the HIV outbreak amongst drug users in Glasgow, because back in the late 80s, early 90s, Glasgow remained relatively free in terms of HIV amongst the injecting drug users, and of course Edinburgh was the hotspot, and that was all to do with, some of the great things that was going on in Glasgow, the syringe exchange schemes and early adoption of opioid substitution therapy, methadone, buprenorphine, etc. Anyway, rather than dwelling on the history, I find it quite interesting now with your attempts to get this, of course, we didn't have PrEP back in the 80s, but now your attempts to get PrEP to those injection drug users, it seems that the legislation and regulation is actually limiting the program. Because I don't know, maybe you can say a little something about even amongst, what would we call them, the chaotic drug injectors. Could you envisage that they would be able, if there were changes in the legislation, regulation, would it be possible to get drug users to take a drug regularly, like PrEP? It's a leading question, Claudia. But
no, absolutely, and thank you for that. I think it's important to understand that the reason we've had an upswing is that the particular use of choice of injecting drugs in Glasgow at the moment is heroin spliced with crack cocaine. So people are injecting 6 times a day. I suspect it's the same in other places, but that was relatively new for the UK. And obviously, we can all see why that will lead to increased possibility for transmission. One thing that Scotland has done, for those of you who don't know our little internal politics, is that healthcare is now separate across the UK, and the Scottish Government has actually been incredibly helpful in really being quite forward-thinking in public health responses, and the Scottish Government was prepared to back safe injecting spaces similar to what they have in Australia and other countries. Our Westminster government, Boris Johnson, said no. So we largely come in Scotland from excellent relationships, which is something I think is tremendously important in terms of policy and collective working across third sector community-based organisations. The way I really see this moving forward is to look at the injectables, the long-acting PrEPs. I don't think we have the resources for people who are at the most vulnerable, the most chaotic lifestyles, to be giving people medication on a daily basis. I think that becomes a different thing if we are looking at long-acting injectable PrEP. And we have a problem with hepatitis C as well. So in my little happy dream world, I want to do a combination prevention for Hep B, for HIV and for Hep C, because we're seeing many people getting reinfections. That's a happy dream world at the moment. And of course, in addition to that, we need to be thinking about social interventions. I think everything is possible, but I think the resources and the feasibility are really very challenging.
Thank you very much for that, Claudia. Just as I'm sorry to grab the stage here, but while I've got you, what about are the syringe exchange is still going in Glasgow? Is there still good provision? You've got good provision, and the kind of follow-up question on that: do you have any indicators? For example, roughly how many needles and syringes per drug injector are you giving out in Glasgow?
I don't have that data to my fingertips, but I know people who do.
Yeah,
so I'd be happy to get that to you if that was something of interest. We have been particularly badly hit during COVID, like many people, and the face-to-face services have suffered, and likewise the health of people who inject drugs has suffered, but I'm sure we're not the only ones with that.
Yeah. Thank you so much. Thanks.
Dear moderators, can I ask a question?
Будь ласка.
Great, thank you. Claudia, wonderful presentation. Thank you. Sort of a great discussion. I sort of, just to follow up on that point that you made in terms of your happy dream world about that sort of combo prevention, and targeting Hep C and HIV within this population, people who inject. Do you know regarding CAB-LA, if there's any clinical trial or clinical research in the works or being planned? This is something that sort of like we had sort of brainstormed with some colleagues back in Greece, actually, because we are sort of concerned about these outbreaks which we had about a decade ago in Athens, in people who inject, and now we're seeing an outbreak in people who are injecting in Thessaloniki, Greece's second largest city. And with some of the infectious disease clinicians and also working in harm reduction as well, we thought maybe this is a population for which a long-acting could be very relevant. There's concerns obviously around the tail with cabotegravir, but maybe if you can kind of reflect on that, please. Thank you, and again, wonderful talk.
Thank you, and thank you for raising that point. I think this would be a really high priority research project to do across several countries. I think this has to be done at an international level because we need the diversity of setting to enable us to make good comparisons and to give us generalizability. Just pulling that back, the reason I say that is that we are very worried about this nice little model of care we've got going in Glasgow. We've demonstrated, it's feasible, but we're really stretched, and I don't think it's generalizable. So I think at scale is what I meant to say here. So I think what we need to do is to be thinking in a very brave way. This is the be brave, be bold moment, and I think this would work really nicely as an international collaboration. And I think it will have to be done because of where the drugs are in their pipeline as within a research framework with consented individuals, so that we can look at some of these outcomes. But I think it is be brave and bold because we can't just address single infections. We have got to look at this in a multiplicity of settings with contrasting demographics. And I would even say make this an even more complex intervention or have a separate strand where we address people's social needs within the research context too. Because as we all know, if you haven't got a roof over your head, if you're worried that someone's going to knife you, and if you're worried about being raped, whether or not you turn up for your injectable PrEP prevention is really totally inconsequential.
Здається, більше немає питань. Подяка в чаті. Дякуємо, Клавдія.
As I can see, there are no more questions. I would like to thank Claudia for this discussion. I would like to thank for the comments and answers. We have depleted our time. We still have 4 minutes. Maybe some people would like to ask the questions. You can write this on the chat if you would like to ask a question. With the help of our technical team, you can get connected and you can say this. Maybe you missed some. Maybe we missed something. Maybe you have raised your hand, and we can give you the floor. In that case, in the remaining time, we can see thanks from our international experts, witnessing that the first day of the conference was a success. I would like to thank all the colleagues because indeed it was huge work. Some people had very early morning, the others had late evening. I would like to thank everyone who could involve and participate in this conference. For us, this is of great importance, and the experience and the best practices and the obstacles you have discussed. How did you overcome those obstacles? This is for the country which has ambitious objectives and implements pre-exposure prophylaxis is of great importance. We have noted those questions, throughput questions that we have heard during the conference. We can quote them now. Or maybe for the discussion, it's better that we focus on them tomorrow before the beginning of tomorrow's event. And we shall summarize what we can see for sure. This is the issue of decentralization, demedicalization of PrEP, reduction of monopolization.
That not only in healthcare facilities, yes, it's a great problem. We have to think about, well, maybe it's not a big challenge, but still we have to think how to regulate it in the sense of the normative regulations. I mean, yes, we have to work on it. And yes, we've got the pipeline issues like more actively involve the PIWD and other key groups, and also about the financing, the social counseling services in operative response, and also to update and amend the those legislative documents for them to be in line with the changes that up to date. And Natalie, your word. Yes, and I would like also to mention that we managed to keep up the bigger part of our participants, like 250 participants still stay with us. And I think that all the speakers and all the moderators did a great work, because we got a good percentage of participation. So, and I really stayed on positive side, because we've got this window of opportunity. Still, we have this support and assistance on the high level, I mean, from the Ministry of Health and from the side of Public Health Center and the international donors. And tomorrow we will listen to our NGOs speakers who will share their experience from the fields, I mean, on implementing PrEP. We will hear to Thailand, Great Britain, and other countries. So I invite all of you to join us. We start 1 p.m. Kiev time. So again, I invite you all, and thanks, a big thanks to the translators, because Roman was the speediest speakers, and thanks to technical support. We've got a participant who wants to say a word, so please give him a floor.
Так, колеги, зголосіться, хто хотів виступити.
Colleagues, who of you wanted to say something, please raise your hands. Okay, I see that we still have questions, like that we missed its HIV, I mean, Miss Will in adverse events, and also okay, we will switch to the summary of the day. And concerning the presentations, you will get the files, and we will resolve all these technical issues since tomorrow. Thank you, Larissa. Our time is over. I don't think that we will get time yet for another speech. Then, say, I suggest to close our first day. So, big thanks to moderators, to organizers, to our international partners, to interpreters, technical support. Thank you very much for sharing your experience. This is very valuable for us. Thank you. Thank you, colleagues, and see you tomorrow. Have a great and nice evening. Thank you.
У мене буде моє маленьке кохання.
У мене будуть нові досягнення, тому що мрії здійснюються. За умови ефективного лікування ВІЛ не передається.
Це найромантичніше побачення. З тобою цінуєш кожну мить. Бо за умови ефективного лікування ВІЛ не передається.
Так круто відчувати усі барви повноцінного життя. Кохати, народжувати, мріяти. Бо за умови ефективного лікування ВІЛ не передається.
Понад 100 тисяч ВІЛ-інфікованих українців уже приймають АРВ-терапію. Лікування безкоштовне та конфіденційне.
У разі досягнення невизначального вірусного навантаження ВІЛ не передається.
Головне – не переривати лікування.
Зроби лише один крок. Не дай ВІЛ зруйнувати твоє повноцінне життя.
Сьогодні він з нею, завтра з ним, післязавтра з ними. Макс не обмежує свої бажання, але розуміє, що ніколи не може бути впевненим у випадкових партнерах. Тому Макс обирає доконтактну профілактику PrEP. PrEP – це таблетки, які не дають вірусу інфікувати організм. Їх приймають щоденно або ситуаційно до та після статевого контакту. Всесвітня організація охорони здоров'я рекомендує PrEP людям, які практикують незахищений секс, мають кілька сексуальних партнерів або партнера, який живе з ВІЛ. Завдяки PrEP Максим залишається здоровим та має свободу вибору. Він думає про себе, про нього та про неї. Подумай і ти. Обери безпечне життя зі свободою вибору. Захисти себе та інших. Зателефонуй на гарячу лінію з питань ВІЛ-СНІДу та завітай на сторінку Центру громадського здоров'я.